conflicts of interest. We do not have any votes today, but just for completeness sake, we will ask you to state whether or not you have any conflicts of interest. I'm going to start to my right, Dr. Talbot.
Good morning. I'm Keipp Talbot. I'm an associate professor of medicine and infectious diseases at Vanderbilt University Medical Center and have no conflicts.
Thank you, Dr. Chen.
Wilbur Chen, professor of medicine at the Center for Vaccine Development and Global Health at the University of Maryland School of Medicine. I have no conflicts.
Thank you, Dr. Lair.
Jamie Lair, Hugo Family Medicine, private practice in Ithaca, New York. I have no conflicts.
Thank you, Ms. Bata.
Lynn Bata, a public health nurse serving as the immunization clinical consultant with the Minnesota Department of Health, and I have no conflicts.
Thank you, Dr. Daley.
Matt Daley, Senior Investigator, Institute for Health Research, Kaiser, Colorado, Associate Professor, University of Colorado School of Medicine, no conflicts.
Thank you. Ms. McNally.
Good morning. Veronica McNally, President of the Franny Strong Foundation based in Michigan, and I have no conflicts.
Thank you. Dr. Sanchez.
Pablo Sanchez, I'm Professor of Pediatrics at The Ohio State University, neonatologist and pediatric infectious diseases at Nationwide Children's Hospital. I have no conflict. Thank you.
Thank you, Dr. Long.
Good morning. I'm Sara Long, Professor of Pediatrics in Infectious Diseases at Drexel University College of Medicine. I have no conflict.
Thank you, Dr. Paling.
Good morning. This is Kathy Paling. I am Professor of Pediatrics and Epidemiology and Prevention at Wake Forest School of Medicine, Atrium Health, Wake Forest Baptist. I have no conflict. Thank you.
Thank you. Dr. Bell.
Sorry, good morning. Beth Bell, Clinical Professor, Department of Global Health, University of Washington. No conflicts.
Thank you, Dr. Bell. Dr. Brooks.
Oliver Brooks, Chief Medical Officer and Acting CEO, Watts Healthcare Corporation, Los Angeles. I have no conflicts. Good morning.
Thank you and good morning. Next is Dr. Sineas.
Good morning, Sybil Sineas. I'm an internist and pediatrician, associate professor of medicine and pediatrics at the Warren Alpert Medical School of Brown University, and I have no conflicts.
Thank you. Dr. Cotton.
Good morning, Camille Cotton. I'm the clinical director of transplant and immunocompromised host infectious diseases at Massachusetts General Hospital and associate professor at Harvard Medical School. I have done work on a clinical antiviral project with Takeda. I have not done any work involving vaccines with Takeda. Thank you.
Thank you. And this is Grace Lee. I'm a professor of pediatrics at Stanford University School of Medicine, chief quality officer at Stanford Medicine Children's Health, and I have no conflicts. And we are at quorum, so we are happy to get started for today's meeting. This morning, we will start with our coronavirus COVID-19 vaccine session. Dr. Matt Daley, who's chair of the ACIP COVID-19's work group, will provide an introduction and overview of today's session. Dr. Daley.
Great. Good morning, all, and thank you very much. So I'm presenting today on behalf of the ACIP COVID-19 vaccines work group. Next slide, please. So to start with an update, bivalent booster authorization was extended to children ages 6 months and older. As you can see on the slide, on December 8th of 2022, the FDA granted emergency use authorization, or EUA, for Moderna bivalent COVID-19 vaccine booster in children ages 6 months to 5 years. And then also granted the use of Pfizer-BioNTech bivalent COVID-19 vaccine as a third primary series dose for children 6 months to 4 years of age. And then the following day, the CDC expanded the use of updated bivalent COVID-19 vaccines for children 6 months through 5 years of age. Next slide, please. So this slide reviews the activities of the ACIP COVID-19 vaccines work group since our last ACIP meeting. And as fits the circumstances, the work group has been very active. The activities have included the following. We've looked at the epidemiology of COVID-19, including MISC. We've looked at hospitalization data. The work group has had a number of vaccine effectiveness updates, some of which we will hear about today. We've also examined COVID-19 among persons with immunocompromise, including vaccine effectiveness in this population. We've also heard EvuShield updates. In addition, we've had discussions about what inputs should be used in upcoming cost-effectiveness analysis. We've had a number of COVID-19 vaccine safety updates. In addition, we did review updated benefit-risk analysis. We've had updates on COVID-19 vaccine use in 6 months through 5 years of age, including the use of Moderna COVID-19 vaccine booster doses. And then, importantly, given coverage in the country in particular age groups and particular populations, we've had extensive discussions about ongoing work to increase uptake of bivalent COVID-19 vaccines. And then several other topics we're going to discuss extensively today. We discussed considerations for the transition to a bivalent primary series, and then discussed future directions for the COVID-19 vaccination program overall. And again, this will be a topic for discussion today. Next slide, please. So here's the agenda for today. First, we're going to hear COVID-19 vaccine safety updates from Dr. Shimabukuro at the CDC. Following that, we'll hear from Dr. Forshee from the FDA, who will also provide COVID-19 vaccine safety updates. Following that, we'll hear from Dr. Talbot, who's an ACIP member and VAST chair. She'll provide a VAST summary of the COVID-19 vaccine safety data. And then Dr. Twentyman from the CDC will provide the workgroup interpretation of these data. We'll then have a brief break. Following that, we'll hear from Dr. Taylor at the CDC, who will provide updates on COVID-19 hospitalizations in the U.S., followed by Dr. Britton, who will provide updates on COVID-19 vaccine effectiveness in the U.S. Then we'll hear from Dr. Oliver, who will discuss considerations for transitioning to a bivalent primary series. Following that, we'll hear from Dr. Twentyman again, who will discuss workgroup interpretation and summary. And then we'll have discussion at that point, followed by a break. And then after the break, we'll hear from Dr. Wallace, who will provide updated benefit-risk analysis for COVID-19 vaccines. And then Dr. Oliver will lead a discussion. We'll present and lead into a discussion of COVID-19 vaccines in terms of future directions for the program. Next slide, please. It's a tremendous amount of work, and it's just a tremendous group. And so I want to thank the ACIP members, excuse me, who are on this group, including Dr. Bell, Dr. Lee, Dr. Talbot, and Dr. Brooks, and then ex officio and government members, liaisons, and consultants, and then the outstanding leadership of Dr. Oliver and Dr. Twentyman. Next slide, please. And then, in addition, all of the behind-the-scenes work from all these individuals and more who prepare all this material for us to review so that we can have the discussions we need to have. Next slide, please. Thank you very much. I turn it back to you, Dr. Lee.
Thank you, Dr. Daley, and thank you for updating the public on all the activities of the COVID-19 vaccines work group in the interim. Before we begin this vaccine safety session, I'm actually going to ask Dr. Sara Meyer, who's the Chief Medical Officer for the Immunization Services Division, to make a few statements.
Hello and good morning. Before we started today's session, where we will be talking about the future of COVID-19 vaccines, we wanted to provide a little bit more information about the federal government's plans to end the COVID-19 public health emergency on May 11th. We've been getting a lot of questions about what this means for the vaccination program, what this doesn't mean for the vaccination program. So before today's session, we wanted to just provide some brief updates on that. First, before getting into that, I just wanted to say that CDC remains dedicated to preventing severe illness and death from COVID-19, with particular concern for populations who are at higher risk of adverse outcomes. CDC is actively working with other federal government agencies and offices to maintain access to vaccines, but to other things like testing and therapeutics to the extent possible. So what is, I guess in terms of the vaccination program, much of the current COVID-19 vaccine program will remain unchanged after the PHE ends in May. The primary impact of the PHE ending on the vaccination program is the possibility of reduced submission of vaccine administration data from some jurisdictions. This is because the data use agreements, or DUAs, for COVID-19 vaccine administration were established with termination provisions that reference the PHE. However, state and territorial public health jurisdictions are being asked to extend this DOA through the end of 2023, and so far the majority of jurisdictions have done so. It is important to note that the end of the public health emergency does not equate to the end of the current national vaccine distribution program or the transition to commercialization. I think this has been one of the biggest points of confusion we have heard about, that the end of the PHE also means the end of the federal vaccine program, and that is not the case. CDC has received many questions regarding commercializing COVID-19 vaccines. We continue to work with HHS on this process and are collecting questions to help ensure we address the needs of jurisdictions and partners as we move towards commercialization in the future. And we will share information with you all as soon as we are able to. Thank you.
Thank you very much, Dr. Meyer. And with that, we will start our COVID-19 vaccine safety session with updates from CDC. Dr. Tom Shimabukuro, who is Director of the Immunization Safety Office. The floor is yours.
Good morning. Next slide. So today I'll describe CDC's vaccine safety data link, rapid cycle analysis, monitoring methods, and assessment processes for statistical signals, describe VSD RCA signal detection and signal assessment for ischemic stroke after Pfizer BioNTech COVID-19 mRNA bivalent booster dose vaccination in the age group 65 years and older, and describe rates of myocarditis and pericarditis following COVID-19 mRNA vaccination. Next slide. So bivalent boosters first became available in the US in September 2022, and as of February, 52.5 million bivalent booster doses have been administered in people ages 5 and older, including 22.3 million doses in people ages 65 and older. CDC and partners monitor the safety of licensed and authorized U.S. vaccines using multiple complementary systems, and the safety data supports CDC recommendations that everyone eligible for a COVID-19 mRNA bivalent booster get vaccinated. Next slide. So now I'm going to move into our findings in the vaccine safety data link, and these slides were prepared by Kaiser Permanente, Northern California. Next slide. So the VSD was established in 1990. It's a collaboration between CDC and 9 integrated healthcare organizations and includes electronic health record data on approximately 12.5 million individuals. Next slide. The strengths of VSD rapid cycle analysis include its population of 12.5 million people, which is about 4% of the US population, across the VSD data sites, which are geographically and racially and ethnically diverse. We use near real-time data with analyses updated weekly. We have access to comprehensive medical records, including exposures or vaccination and outcomes, allowing rapid chart reviews to obtain additional clinical information as needed. The VSD employs innovative methods for RCA, the vaccinated concurrent comparator method. This is our primary analysis. Now, recent vaccinees as comparators are expected to be more similar to current vaccinees than unvaccinated individuals, with the following advantages that we can carefully adjust for the potential biases associated with calendar, time, site, and demographic factors. These analyses can begin sooner than alternative methods. We also use supplemental analyses that we conduct weekly. Unvaccinated or unboosted comparators would also be available to provide context in real time. And we believe that using vaccinated concurrent comparators with supplemental analyses offers substantial benefits compared with either unvaccinated or historical comparators. Next slide. So the primary methodology for RCA for the primary analysis is the vaccinated concurrent comparator method, and we've used this for bivalent boosters and for the primary series and monovalent boosters. Pre-specified outcomes were assessed during weekly sequential monitoring after bivalent booster vaccination. The risk of pre-specified outcomes 1 to 21 days, the risk interval following a bivalent vaccination compared with bivalent vaccinated individuals who were 22 to 42 days following the bivalent dose. That's the comparison interval. All analyses are adjusted for age, sex, race, ethnicity, VSD site, calendar, time, and seasonality. and our signaling threshold is a one-sided p-value less than 0.01. Next slide. So this is a schematic, which I think you've seen before, of the vaccinated concurrent comparator method. And what you see here is a vaccinee with an outcome in the risk interval and a concurrent comparator. So on the top, you have this vaccinated individual with an outcome. That's the figure with the heart. This individual, this is hypothetical, but was vaccinated in September 30th and then had an outcome on October 3rd. So this person is in the risk interval, 1 to 21 days post-vaccination. On each calendar day that an outcome occurred in a vaccinee, we compare with vaccinees we compared vaccinees in their risk interval with similar vaccinees in their comparison interval on days 22 to 42, which you see on the bottom of the figure here. There's an individual in the comparison interval on the same day. And by similar, we mean on the same calendar day, they were in the same age group and of the same sex, race, ethnicity, and at the same VSD site. So the bottom line, we're looking at incidence of the outcome, the pre-specified outcome in vaccinated individuals in the risk interval compared to incidence of the pre-specified outcome in vaccinated individuals in the comparison interval. Next slide. So I'm going to take some time just to discuss VSD investigations of a signal to assess whether it reflects a real effect of vaccination on an outcome. And these investigations include data quality assessment for errors, anomalies, or missing or late arriving data, analyses using different comparators than the primary concurrent comparator, such as unboosted, unvaccinated, or historical comparators, additional investigations to provide context, such as looking at background rates, graphic displays of outcome incidents day by day after vaccination using temporal scan statistics to assess apparent clustering. If a signal is driven by a strong association in one subgroup or VSD site, further analysis by site or subgroup as appropriate, chart reviews to confirm cases and collect additional data. And lastly, we would consider epidemiologic studies to further investigate surveillance findings. Next slide. So using the methods I just described, VSD conducted RCA for the pre-specified outcomes shown here. One statistical signal was identified for ischemic stroke after Pfizer bivalent booster vaccination in the age group 65 years and older, and I will review that in more detail shortly. No signal for ischemic stroke was observed after the Pfizer booster in persons aged less than 65 years or after Moderna vaccine in any age group. And no other pre-specified surveillance outcomes have signaled in any age groups for either of the bivalent booster vaccines or when the data for the two vaccine types are combined or pooled. Next slide. So moving into the results for the preliminary analysis of the ischemic stroke signal in people 65 and older. Next slide. So this figure shows the number of COVID-19 bivalent booster doses and influenza vaccine doses administered over time in people 65 and older in the VSD. So on the y-axis there, you have number of doses administered, and on the x-axis, you have time, and that coincides, you have these weekly looks which coincide with the RCA sequential analyses. So the red and the blue lines are bivalent booster doses with Pfizer in red and Moderna in blue. And then you see all influenza types layered on top of that. So a couple things that are important on this slide. There was substantially more Pfizer bivalent boosters administered in the VSD compared to Moderna boosters, 580,000 versus 309,000. And there was substantially more Pfizer bivalent boosters administered in this age group early on in the bivalent booster program. And this peak of bivalent booster vaccination, again, most of which was Pfizer in this age group, was also occurring at the same time of peak influenza vaccination. Next slide. So this is a reference slide showing the VSD RCA ischemic stroke definition. And this included transient ischemic attack codes plus the cerebral infarction code. And it also included some exclusion criteria, so a personal history of TIA or cerebral infarction without residual deficits, and sequelae of cerebral vascular disease. Another exclusion criteria was COVID-19 in the last 30 days prior to an incident case, and this included a COVID diagnosis or a COVID-19 positive lab test. Next slide. Next slide, please. Thank you. This is a table showing the main findings, the main current findings for the bivalent RCA concurrent comparator analysis of ischemic strokes during the risk interval versus the comparison interval. So on the left-hand side of this table, you see the age groups 18 to 64 and 65 plus, then the two vaccines, and then you have cases or risk events, cases in the risk interval, comparison events, cases in the comparison interval, and then the adjusted rate ratio and the 95% confidence interval for the nominal analysis. And then on the far right, you see the criteria for signaling in the sequential analysis. Again, the one-sided p-value less than 0.01. So if you're able to see the presentation that was given at the VRPAC meeting a few weeks ago, you have noticed that this bolded Pfizer line, this bolded Pfizer row in the 65 plus was actually red at that time, and there was a yes for a signal because of that analysis. It was meeting the threshold for a statistical signal in the sequential analysis. Since then, it has attenuated, and we have an adjusted rate ratio of 1.36. A nominal confidence interval of 1.05 to 1.76, but not meeting the sequential statistical the threshold for a statistical signal. Next slide. So this is showing some of that information for that particular analysis that I just described over time. So this, just to orient you to this graph, on the x-axis you have time, and it's by week for these weekly sequential analyses. The blue bars represent cases in the risk interval. The orange bars represent cases in the comparison interval. You see them side by side at the week of analysis. And then the gray line represents the rate ratio. And where you have a red dot at the specific analysis, that means that it met the threshold for a statistical signal in our sequential monitoring. So the last week in November, on November 27th, we signaled for ischemic stroke following Pfizer bivalent booster in age 65 and older. This is 65. This is data on 65 and older. At that point, the rate ratio was 1.92, and that statistical signal persisted for 8 weeks, although it attenuated slightly. And in the past several weeks, it's intermittently met the signaling criteria. Right now, the rate ratio is 1.36 and does not meet the signaling criteria. I want to caveat that by saying that in VSD RCA, once you signal, you always signal. So you don't unsignal, but we continue to do the weekly sequential analyses because we think it's informative, and we do document where it drops below the signaling threshold. Next slide. So this graph shows ischemic stroke by day after the Pfizer bivalent boosters in people ages 65 and older. This is the temporal scan analysis. The light blue bars represent case counts, and then that darker blue line is the rate per million person days. And what you see here is we have detected a statistically significant cluster of cases on days 13 to 22 following vaccination. And you'll remember that our pre-specified risk interval is days 1 to 22. So something to note about that that cluster, and I don't have the data for myocarditis, but if you compare this cluster to what we observed for myocarditis, which was a very prominent clustering several days after vaccination, compared to that, this this cluster is a little more subtle and not so well defined, but it is a statistically significant cluster nonetheless. Another thing to notice here is if you look at the rate, and again, that's the dark blue line, if you look at the rate preceding this statistical cluster on days 13 to 22, so that's the time on the far, that's the rate on the far left-hand side of this graph. And then you compare that to the rate in the comparison interval or the comparison interval plus. Visually, it looks like there may be a lower rate in the comparison interval compared to the time in the risk interval prior to when we see this statistically significant cluster, implying that there may be lower than expected counts in that comparison interval. And I'll describe this a little in more detail in some later slides. Next slide, please. So our colleagues at Northern California did a review of a subset of cases. They actually pulled some of the charts for the cases in the initial cluster, which was slightly different. It was 11 to 21 days. It's evolved over time. But they pulled cases in that cluster and reviewed those. It was a subset of 24 cases. And of these 24, 22 were incident stroke or TIA cases. That's a positive predictive value of 92%. None had any history of stroke or TIA. The median age was 77.5. Symptom onset rarely shifted from the electronic date. 5 or 23% had a known history of SARS-CoV-2 infection, only 1 within the last 6 months. None mentioned recent exposure to SARS-CoV-2 in the chart notes, and 14 or 64% of these cases had flu vaccine co-administered on the same day. And of those 14, 13 were high-dose flu vaccines and 1 was adjuvanted. As far as these 22 verified cases, as far as the outcomes, 13 of 22 or 59% were discharged home, 18 were discharged home with home health, 9% were discharged to a skilled nursing facility, 14 and 3 of 22 or 14% died. 1 death was in a 75 to 79-year-old male, approximately a month after the stroke, and the death was likely related to the stroke. Another was in a 65 to 69-year-old female, noted after craniotomy, although the relationship to surgery was unclear. This death was due to cardiac arrest about 2.5 months later. And then the last case was in a 70 to 74-year-old male during hospitalization for metastatic cancer with subsequent death due to cancer-related complications during hospitalization. And we're currently reviewing a random sample of risk and comparison interval cases across VSD sites. Next slide. So I mentioned that we do supplemental analyses as well. And one of the supplemental analyses we did was looking at ischemic strokes during the 1 to 21 day interval, comparing bivalent boosted versus unboosted concurrent comparators, but eligible for a bivalent booster. So this is basically looking at boosted versus unboosted individuals in the 1 to 21 day risk interval. It's essentially a vaccinated versus unvaccinated analysis, but the unvaccinated individuals are still highly vaccinated because they're eligible for a booster and are likely to be fairly similar to boosted individuals. In this analysis, the adjusted rate ratio was 1.07 and not statistically significant. So in this supplemental analysis, we did not signal for ischemic stroke. Next slide. This is additional supplemental analysis looking at ischemic strokes during the 22 to 42 day interval, comparing bivalent boosted versus unboosted concurrent comparators, but eligible for booster. So the top row of this table is what I just showed you. The bottom row, and this is not so intuitive, but what the investigators did was essentially perform the same analysis, but use a different interval. In this case, the 22 to 42 day interval. And what they found was an adjusted rate ratio of 0.76 with a 95% confidence interval 0.6 to 0.95. So actually a protective effect when you looked at the 22 to 42 day risk interval. And these findings suggest a reduced rate of stroke in the comparison interval, getting back to that temporal scan graph that I showed you where it looked like there may have been a lower rate in the comparison interval. Next slide. So as I mentioned previously, a fairly high percentage of these of the cases in the chart review noted simultaneous high-dose or adjuvanted flu vaccine. So there was an additional post-signal analysis looking at simultaneous vaccination. Next slide. So this table shows ischemic stroke incidence during days 1 to 21 compared with days 22 to 42 among individuals 65 and older with and without simultaneous flu vaccination. So on this top highlighted row, the population here are those individuals 65 and older that received a bivalent Pfizer booster plus same-day high-dose or adjuvanted flu vaccine. So booster plus simultaneous high-dose or adjuvanted flu vaccine. You see 43 cases in the risk interval, 26 cases in the comparison interval. The adjusted rate ratio was 1.65 and just met statistical significance. The lower bound of the 95% confidence interval was 1.02. The middle row is really not that informative, but if you go down to the bottom row, this population here is those 65 and older that got a bivalent Pfizer booster without any same-day flu vaccine. And you see the adjusted rate ratio is 1.19 and is not statistically significant. Next slide. So this is a follow-on to that analysis I just showed, looking at expected cases after bivalent booster plus high-dose or adjuvanted flu vaccine based on ischemic stroke incidence in unboosted people eligible for a booster. So this analysis was actually done looking at the older age group in 5-year increments, but probably the best thing to do is focus on that bottom row there, total. So in the column that's titled expected cases in a 3-week interval, risk or comparison, that is really, you can consider that an expected background number of cases based on looking at the VSD data in total. And you see 38.7. And then you see the observed cases in the 1 to 21 day risk interval and the observed cases in the 22 to 42 day comparison interval. Could you just go back to the previous slide real quick? So that 43 and the 26 are from this analysis right here. Could you go to the next slide? So what this is doing is basically seeing how do those observed cases in the risk interval and the comparison interval compared to what we would consider a background in general in the VSD. And what you can see from this analysis is that the observed cases in the risk interval are slightly above the background. So 43 compared to 38.7. And then if you look at the observed cases in the comparison interval, relatively speaking, they're substantially more below the expected background. So 26 compared to 38.7. And so again, these findings also suggest a reduced rate of stroke in the comparison interval. Next slide. So to sum things up, this statistical signal persisted for 8 weeks. The rate ratio has slowly attenuated from 1.92 to 1.36 and intermittently met signaling criteria. Temporal clustering evaluation found a significant cluster 13 to 22 days after vaccination. Supplemental analyses using unboosted concurrent comparators showed a rate ratio of 1.07, which was not statistically significant. Of a small subset of charts reviewed, most confirmed cases had co-administered high-dose or adjuvanted flu vaccine. Analyses evaluating simultaneous high-dose or adjuvanted flu vaccine showed a rate ratio of 1.65, which just was statistically significant. Separate analyses did not detect an elevated rate ratio for stroke after flu vaccine alone. And supplemental analyses suggest the comparison interval rates were lower than expected. Next slide. So some additional considerations include the small number of strokes and imprecise rate ratios limit some analyses. Reduced follow-up time after Moderna booster dose. There was reduced follow-up time after Moderna booster dose due to distribution delays, and simultaneous flu vaccine analyses were limited by small numbers. It is difficult to interpret temporal clustering during risk and comparison intervals. There's possible unmeasured confounding. The results may be influenced by confounders that vary over time. There's a question of, do early adopters of bivalent booster vaccination have greater risk of near-term cardiovascular events, although the same trend has not been observed for acute myocardial infarctions. And there's the potential impact of differential vaccine availability after the EUA. There are simply more Pfizer available and administered in VSD than Moderna. There's also the possible role of SARS-CoV-2 infection before the booster. Background incidence of SARS-CoV-2 infection was rapidly changing during bivalent booster uptake. Analyses did exclude cases with COVID-19 diagnosis or positive lab tests prior to 30 days, although asymptomatic infections and home antigen tests are not consistently documented in an electronic health record. However, chart reviews did not find recent SARS-CoV-2 infection or exposure. Next slide. So we'll continue to monitor weekly and explore potential data-related explanations for the statistical signal in VSD. We'll consider expanding chart reviews to all, we will be expanding chart reviews, a random sample to all VSD sites. We'll consult with other surveillance systems to better understand the possible role of simultaneous high-dose or adjuvanted flu vaccination with COVID-19 vaccination and the possible decreased rate of stroke in the 3 to 6 weeks following vaccination. Next slide. Just to touch on some data from other systems or programs. There have been no unusual or unexpected reporting patterns observed and no evidence of a safety concern detected for ischemic stroke with either bivalent boosters in VAERS. FDA monitoring and CMS data and VA monitoring in the VA system have not detected any safety signals using the historical comparator designs. And surveillance conducted by international regulatory and public health partners has not detected a safety concern for ischemic stroke following bivalent booster vaccination. There's been no evidence of a safety signal for ischemic stroke in Pfizer's global monitoring, and no safety signals were detected for ischemic stroke for the primary series or monovalent boosters for Pfizer or Moderna vaccines in US and global monitoring, although these surveillance activities did not include analyses to evaluate the effect of simultaneous flu vaccination. Next slide. So CDC continues to recommend that everyone eligible for a COVID-19 mRNA bivalent booster or flu vaccine get vaccinated, and CDC and FDA are engaged in epidemiologic analyses regarding co-administration of bivalent booster and flu vaccines. Next slide. So I'm going to wrap up with a few slides on myocarditis and pericarditis following COVID-19 mRNA vaccination and VSD, and these data will be used in later presentations in this session. Next slide. So this graph shows bivalent booster uptake in VSD in persons aged 12 to 39 years by vaccine type. There is 135,000 Moderna bivalent boosters administered and 431,000 Pfizer boosters for bivalent boosters for a total of about 566,000. Next slide. So this is a pretty busy table that's showing the VSD incidence rates of verified myocarditis or pericarditis in the 0 to 7 days after Pfizer vaccination in people ages 12 to 39 years. You've previously seen the dose 2 and the monovalent. What's new are these bivalent booster dose rates, which you see on the far right there. And I can say that the data are pretty limited, but the data we have are not showing any new or unusual findings. There's actually only been one case in a male aged 18 to 29. But what you can see from this table of this table of several vaccinations is that in the high risk age and sex strata, so that's adolescent males and young adult males, you see the highest rates. highest incidence rates after dose 2 of the primary series. And then you see these rates, which are somewhat lower after the monovalent booster dose, and then lowest after the bivalent booster, with the caveat that the bivalent booster dose, the bivalent booster data are quite sparse. You're not really seeing much of a difference across dose 2 and first monovalent for females, or when you get to the age 30 to 39 strata. Next slide. So this is a similar table, but for Moderna. There were such few doses administered in the 12 to 17. It's not informative, and we're not showing that. So this is data from 18 to 29 and 30 to 39. And you're seeing the same general trend again. The highest incidence rates in males after dose 2, although there are wide confidence intervals around these point estimates. And then lower incidence rates after the monovalent booster dose, and then the lowest after bivalent. Of course, again, very sparse data for bivalent boosters. And then really not much of a difference in incidence, and much lower than in males for the females in the 18 to 29, and then not any substantial differences across the different vaccinations, dose 2 or monovalent, once you move into the 30 to 39-year-old age group. Next slide. I'd like to acknowledge the following groups for their contributions to this presentation. Next slide. Next slide. And that concludes my presentation. Thanks.
Thank you very much, Dr. Shimabukuro. This just for clarification for our committee members, we're going to have 2 presentations, and VAST will provide a summary as well as a work group summary. So we'll ask if you can focus on clarification questions for Dr. Shimabukuro. That would be wonderful. Thank you. Dr. Paling?
Dr. Shimabukuro, thank you and your the huge team behind all of this work and walking us through what the data does and does not show us. And it provides me tremendous confidence that people are looking so diligently, and then also looking across different systems to see if we find the same or different things. I wanted, and I appreciate hearing that in the VA system we don't see a signal, and we don't see a signal in the CMS system. Is there surveillance going on in nursing homes?
I'm not aware of specific surveillance in nursing homes, although I will say that that some of these individuals in the VSD analysis maybe in nursing homes. And then if Dr. Forshee is on, he may be able to provide some additional insight on nursing home residents and the CMS data. I'm not familiar with that, as familiar with those data.
Hello, this is Rich Forshee from the FDA. For our Medicare analyses, which I'll be discussing in just a moment, we do not include nursing home residents in our sequential analyses, although we have done some separate analyses on nursing home residents, but not specifically for this outcome of ischemic stroke. I hope that's helpful.
Okay, so that's thank you for that clarification. I look forward to your presentation. And can we go back to slide 19? I want to make sure I'm understanding the secondary analysis correctly. I think it's the supplemental analysis about 1 to 21, and yes, and all right. I'm looking for supplemental, and yeah, all right, you're still working.
This one, wait, no, go. This one here. This is the primary. Well, this is the supplemental analysis. The primary analysis is the vaccinated concurrent comparator. This is the supplemental analysis, the boosted versus unboosted.
That's right. I wanted to look at the next slide. Yes. Okay. In understanding the highlighted red bar, I wanted to make sure that I'm understanding this correctly. So this is saying if you look at the secondary analysis at 22 to 42 days, and I'm comparing the vaccinated with a bivalent booster versus someone who's vaccinated but hasn't had the bivalent, they have fewer strokes. Is that the correct direction in understanding this data? Thank you.
So you're not, this again, I said this is not the most intuitive analysis to understand. So this is boosted individuals compared to unboosted individuals using the 22 to 42 day risk interval. So I don't want to try to mentally do the math.
about both COVID-19 and influenza, their relationship to stroke, and to better understand potential protective effects of vaccination, given the limitations reflected here. And in our collective effort to interpret the safety signal discussed today, we were particularly interested in these outcomes within the population of people ages 65 years and older. Next slide, please. We at CDC were able to initiate pursuit of these questions through two large healthcare data sources, which I will briefly describe here. The National Patient-Centered Clinical Research Network, better known as PCORNet, is comprised of electronic health record data from ambulatory, emergency department, and inpatient settings. It covers all patients, in other words, with and without insurance, in participating health systems, or about 10% of the U.S. population, including those ages 65 years and above. There is almost no lag in this data because it comes directly from participating PCORNet sites following structured inquiries and does not have external dependencies such as processing of claims. We used this data to rapidly assess incidence of stroke across this diverse population among those with recent COVID-19 or influenza and incidence overall in this population. Health Verity, on the right here, is a massive healthcare data source, including medical claims from closed payer systems related to ambulatory, emergency, and inpatient settings. The data is linked to vaccination data from the Federal Retail Pharmacy Program using Health Verity's privacy-preserving record linkage technology. It covers patients insured through Medicare Advantage, or about 25% of the U.S. population ages 65 years and above. There is an approximate 3-month lag in data when using closed claims. We use this data to assess incidence of stroke across the insured U.S. population with recent COVID-19 or influenza vaccination and incidence overall in this population. Next slide, please. Methods used in each of these data sets were designed to capture incident strokes. Patients with history of stroke were intentionally excluded to attempt avoiding overestimation of incidence. As a result, we may have undercaptured strokes, as history of stroke and TIA is associated with risk of stroke. ICD-10 codes were generally chosen to align with the definitions of stroke used in Vaccine Safety Data Link. I'll make one more point here, which is with respect to the choice of interval used. As you can see at the bottom left of this slide, we used an interval of 3 days prior to 28 days post COVID or flu diagnosis within which to calculate stroke incidence. While, as you can see on the bottom right of this slide, we used an interval of 0 to 28 days from receipt of vaccine to calculate stroke incidence. As you recall, we know that stroke and COVID symptoms often present simultaneously, as do stroke and flu symptoms. Stroke is frequently an early complication of respiratory disease. And while healthcare data can identify the exact date and time of the administration of a vaccine, that is not true of the onset of COVID or influenza infection or its symptoms. Use of the interval of -3 to 28 days around diagnosis allows us to identify, for example, those patients who are admitted with acute stroke, get tested for COVID-19, for example, and have a positive test that results on day 1 or day 2 of their hospital stay. Next slide, please. We observed a high incidence of stroke following both COVID-19 and influenza diagnosis in the PCORNet data over the late Omicron period of 2022. You'll see that the y-axis ranges from 0 to 10,000 strokes per million. In the -3 days prior to COVID diagnosis to 28 days post-diagnosis, we observe an incidence of approximately 8,800 incident strokes per million over these days. Although we do not have a current estimate of incident stroke in the United States, we are able, using this healthcare data, to calculate average incidence of stroke in this population in this data set over 32 days. And note that this comparison is visually striking. I will note, however, that groups presented are of the same age category and adjusted time at risk. Crude incidence within these groups is not otherwise adjusted. Next slide, please. This is the same
slide you just saw presented, but now with lines demonstrating the proportion of incidence of stroke within 3 days preceding or 7 days following diagnosis of COVID-19 or influenza. Again, stroke appears to be an early complication of disease. Next slide, please. As we move to this slide, I want to alert you first to the change in the magnitude of the y-axis. It's no longer 0 to 10,000 strokes per million. It's now 0 to 1,800 strokes per million. Average stroke incidence among adults ages 65 years and older in the overall health verity population over 28 days is slightly less than 1,400 strokes per million over this time period. In contrast, you'll see that we observe a very low incidence of stroke in the recently vaccinated population. It's important to underscore again, though, that these are observations of crude incidence in these groups, which are within the same broad age category of 65 years and older, and which are adjusted for time at risk, but are not adjusted for any other potential confounders, such as underlying medical conditions or older age groups. We are not presenting attributable risk. We are not assessing causality in any way. Nevertheless, these are helpful observations. Next slide, please. Let's turn now to workgroup interpretation and next steps. Next slide, please. The workgroup believes that the review of safety data is reassuring and must continue. The priorities identified by the workgroup include continuing to closely follow the intermittently statistically significant signal in VSD with continued review by VAST and colleagues, continuing supplementary analyses to clarify the relationship between this signal and any specific vaccine, co-administration of vaccines, and or confounding, and continuing the most intensive vaccine safety surveillance in United States history. While the data pertaining to vaccine safety is reassuring, in contrast, the data pertaining to COVID-19 disease and influenza was not so reassuring. Based on the review of healthcare data demonstrating high incidence of stroke with COVID-19 or influenza, the priorities identified here include increasing awareness of the risk of stroke with COVID-19 disease and influenza, and continuing to encourage uptake of the bivalent COVID-19 boosters. Next slide, please. In summary, the COVID-19 ACIP workgroup remains confident in current COVID-19 vaccine recommendations and does not recommend any changes to current recommendations, including those regarding co-administration of vaccines. CDC and partners anticipate the opportunity to review and consider upcoming analyses prior to the 2023-2024 flu season. Next slide, please. This presentation and the data within it represent the work of many scientists and partners. I'd like to particularly thank the healthcare data teams for making these very current analyses possible, the Division of Heart Disease and Stroke Prevention for the critical guidance, the experts across NCIRD for their tireless dedication, and to our vaccine safety colleagues for their incredible vigilance. Thanks all.
Thank you so much, Dr. Twentyman. And this presentation, or sets of presentations, all four, this session is now open for questions. Dr. Lair.
I'd like to thank you for that summary. If you could go back to the slide, the stroke incidence with influenza and COVID infection. I have a comment and then a general question. My interpretation is that it's very clear that we have a high risk of stroke with influenza and COVID, and yet we have a very weak signal of risk for stroke after a COVID infection. And so it's fairly clear to me that the benefits of vaccination and preventing strokes that we know are going to happen outweigh the possible tiny risk of the vaccination. So I just want to say that out loud because I think that's a very important conclusion. My general question is for everyone. We're studying risks in the first 3 weeks or a few weeks afterwards. Are any of these surveillance systems looking at possible risks longer term, 3 months afterwards. And I haven't heard that, and I'm not sure if I've just missed that somewhere. Thank you.
I'm actually going to turn that over to the second question. Oh, sorry. Yes, the second question or the second comment over to Dr. Shimabukuro and Dr. Forshee. Would you like to respond? And just, if you couldn't hear, the question was focused on whether or not there was any longer-term safety surveillance.
Hi, this is Dr. Shimabukuro. I think I guess what are you asking? Are we considering extending the risk window out longer? Is that the question?
No, I have a very vaccine hesitant population in my community, and I can tell them a lot of good data about how we don't find signals, but then they say, oh, are they studying this for months? Do we know about some possible side effects of vaccines down the road? And I can't give them a good answer, at least at this time. And I tell them we know the risks of the disease, and so I tell them I still want them to vaccinate, but if we had information about any of these surveillance systems, I haven't heard of any. I'm just curious if there are some.
Okay, I understand. So I would say in the VSD rapid cycle analysis, I mean, we specify upfront our risk interval and our comparison interval. In VAERS, our spontaneous reporting system, there is no, we monitor all reports that come in regardless of the time from vaccination, and those all get included. Also, regardless of the plausibility of the vaccine causing the event or the vaccine causing the event within some specific time frame. So we do, in VAERS, we are able to look at all events at any time after vaccination for the adverse events that are sent into us. In our rapid cycle analysis in VSD, we do have to specify these risk periods and comparison periods up front, though.
Thank you.
And hi, this is Rich Forshee from the FDA. First, I agree with everything that Tom just said. A couple things that I will add. The sequential analysis systems that both Dr. Shimabukuro and I have discussed today, they are largely intended to generate timely results, and so we look for the plausible risk windows shortly after vaccination, because those data, of course, accumulate more quickly, and we're able to more quickly conduct those analyses. It is also easier to evaluate whether there's a causal association if they're more proximate in time as we move out to longer time periods involving months or years. So many other factors can have affected the risk of those events in the longer time periods that it becomes a little more difficult to conduct those analyses. It is possible in these systems to look at longer time frames, but for the reasons I just mentioned, we start with the focus on the period shortly after vaccination, where it's more plausible that if there is a risk, it's going to be in that shorter period after vaccination, and it allows for a timely analysis of that risk. I don't know if Dr. Shimabukuro has anything to add to what I've just said.
No, thanks, Dr. Forshee. Completely agree.
Thank you. Dr. Paling?
I want to say thank you to everybody and to Dr. Twentyman for providing the balance of what the risks are, as Dr. Lehrs appropriately stated, and echo how important this is the most intensive vaccine surveillance ever undertaken. I want to go back to slide 8 and make sure that I am interpreting things correctly. And I think that's the COVID-19 disease and acute ischemic stroke slide. And so this slide is clearly demonstrating, so yes, thank you. And so we see clearly that COVID disease is strongly associated with stroke, as is flu. And my interpretation on the right is that we have seen the signal for stroke during all the variants thus far, and it is a consistent signal. And I wanted to verify that as a correct interpretation. Thank you.
Thank you so much. I would say we have observed a consistent association between COVID-19 disease and increased risk of stroke across all variants. Yes, so the stroke has been there and unfortunately continues to be there.
Dr. Sanchez.
I had a question in terms of the slide, stroke incidence among all adults 65 years and older. The next one. Oh, that's it. Is this, when you looked at co-administration with a bivalent, did you look at both of them, or were you able to separate it out by Moderna versus Pfizer?
Thank you. We were able to separate out Moderna and Pfizer. In other words, we were able to separate that second bar into two separate bars. Dr. Mulia, I'm trying to figure out the slide I could reference there. It is one of the very last. There we go. Yeah. So this shows separate Pfizer and Moderna bivalent mRNA vaccination. We did not separate out co-administration between whether co-administered with Pfizer or co-administered with Moderna. So this is that second bar split out such that you can barely see those little bars, but they are there. Thanks.
Thank you. And I wanted to slightly differ from Dr. Lair's perspective, and I'll explain why. If you look, so I have a couple of quick points, and then we'll turn it over to Ms. Hayes, and then we'll wrap up the session unless there's any other burning questions. In terms of thinking about how I interpret the safety data. So Dr. Talbot did a very nice job being very objective about how this information is presented. But when I look at the totality of data, including the data from, for example, from Health Verity and PCORNet, to me, it is clear that there is a risk of stroke following infections such as COVID-19 and influenza infection. We are also seeing a protective effect of vaccines against some of these complications of infections such as stroke. Then reflecting back on the vaccine safety data we saw earlier, and I'll ask my colleagues to see if anyone disagrees, but my interpretation is that the signal, and I think Dr. Lair was balancing what is the risk of vaccination versus the risk of infection. I'm not convinced that there is a true signal. I am thinking that actually that signal that we're seeing is partly the protective effect of vaccination. So I'm not even sure if there is a signal, but I still think it deserves further investigation. I really appreciate the team's transparency and conversation around this, and I still strongly feel that the benefits of vaccination outweigh the risks. I'm getting some faces around the table, so folks can disagree with me. But I do think that this continues to be studied over time. So I don't think that, I'm not saying that we should ignore it. I'm just saying that I don't think that I'm convinced that that is a real signal given the totality of the data that we've seen today. The other thing I just wanted to mention is that I want to just also recognize sort of the many unsung heroes. So while we are sitting around this table and people might know our names, I think there are so many individuals who have contributed, and also just wanted to highlight this really is kind of a private partnership in that there are many federal agencies who have done a phenomenal job in bringing these types of data to us. there are also many partners, often academic partners or health system partners, who are behind the scenes doing all of this incredible work week after week. So those 71 meetings when we're looking at data, all the teams behind that data are actually delivering that data so we can review it together. So again, it's just a tremendous effort, and I want to thank all of our colleagues, too many to be named, who have continued to be able to provide that level of information and under really difficult circumstances, and being asked to do it in a real-time way so that we can then bring this information to the public as quickly as possible. So I am confident that with such robust systems that we'll continue to re-look at the data and review this data and continue to assess the benefit-risk balance, and we will always reevaluate where we are as we get more information. But I personally feel confident today in the role of vaccination. Any additional questions from our members? And then I see Ms. Hayes, do you have a comment or a question?
Yes, I do. Thank you. Carol Hayes with the American College of Nurse Midwives. I want to reiterate what you just said, Dr. Lee, that the teamwork and the amount of grinding down into the sand of this data is so reassuring, and I'm so thankful for it. And I have a specific question for Dr. Twentyman. So when we're trying to talk to the public, and I've been saying this until I'm blue in the face, but I feel like I need like a simple little number. So on the slide that you presented that showed the stroke incidence among adults over age 65 and recently vaccinated, could you give me, maybe not the second, my brain can't do this math, but could you give me like a number that says your risk of having a stroke over age 65 is 100 times higher than your risk of having a stroke after getting vaccinated? Is there any way that we could give a simple number to the public that says the vaccine is so much safer than getting the disease?
Thank you so much for the question, and thank you for your work in speaking with the public to encourage vaccine uptake. I'd ask everyone listening on this call to do so as we hope to continue to encourage bivalent booster uptake that has not been what we had hoped for the sake of public health. I want to say these observations of crude incidents don't demonstrate attribution or causation. While we are reassured to observe this low stroke incidence in these recently vaccinated populations, well below the average incidence in the population overall here, which you see in that gray bar, we are not controlling for anything here other than the vaccine that might be contributing to that. For example, people that were healthy enough to go get their vaccines in the past 28 days might have fewer of the risk factors associated with stroke than the average person in this population. So there is more to do here, and in fact more that we can do with these data sets. I'll point out that these data sets have already been helpful in that they've facilitated an approximation of baseline incidence. There's not currently a nationally representative estimate of stroke incidence in the US, but these large healthcare data sets like PCORNet and Health Verity allow us to estimate average incidence, at least in these populations. What I do think you can say, not just because of the data presented on this slide, but the wealth of data that we've covered today, is that we believe that the COVID-19 vaccines are safe and effective. We do not think COVID-19 is safe. And if that helps, that would be the message I would share with your patients.
Thank you.
Thank you very much. And with that, we're going to take a 5-minute break, and we'll reconvene at 5 minutes after the hour. Thank you. And thank you to all our speakers. Thank you, everyone, for allowing us to have a quick break. We are now ready to start part 2 of the COVID-19 vaccine session today, which we'll start with Dr. Chris Taylor from CDC, who will provide updates on COVID-19 hospitalizations from COVIDnet.
Thank you very much. Good morning, everybody. Rates of COVID-19 associated hospitalizations for both adults and children and adolescents are looked at more closely in the next 2 slides. Next slide. This slide shows 2 figures. The left figure shows the rates of COVID-19 associated hospitalizations among adults by age group from March 2020 through February 2023. The figure on the right in the red box is at the same scale as the figure on the left, but includes only data from the most recent 6 months of August 2022 through February 2023. In the most recent 6 months, rates among adults ages 75 years and older, indicated by the dashed blue line, have remained elevated relative to younger adult age groups. For both the Delta and early Omicron peaks in January 2021 and January 2022, respectively, rates among adults ages 75 years and older, the dashed blue line, were about 2 times as high as those in the next youngest age group, adults 65 to 74 years, indicated by the solid yellow line. For the last 6 months, however, rates among adults ages 75 years and older have been 3 times as high relative to adults 65 to 74 years. Next slide, please. This slide also shows 2 figures. The left figure shows the rates of COVID-19 associated hospitalizations by pediatric age groups from March 2020 through February 2023. The figure on the right, again, in the red box, is at the same scale as the figure on the left, but includes only data from the most recent 6 months of August 22 through February 23. In the last 6 months, rates among children less than 6 months of age, indicated by the dashed dark blue line, have remained elevated relative to older children and adolescents. Next slide. Again, this slide shows 2 figures. The figure on the left shows the proportion of hospitalizations comprised of adult age groups from March 2020 through February 2023. In the figure on the left, the proportion of hospitalizations comprised of adults 75 years and older, indicated by the yellow area at the top of the figure, has increased steadily since the summer of 2021. The figure on the right in the red box, again in the same scale as the figure on the left, but with data only from the most recent 6 months, shows that about 40% of all adult COVID-19 hospitalizations in the past 6 months have been among adults ages 75 years and older, with 60% of all hospitalizations among adults among ages 75 years and older. Next slide. On this slide, the left figure shows the proportion of hospitalizations comprised of pediatric age groups, again from March 2020 through February 2023. Figure on the left shows the proportions of hospitalizations comprised of infants less than 6 months of age, indicated by the green area on the bottom, have increased steadily since March of 2022. The figure on the right, again the most recent 6 months of data, shows that infants less than 6 months of age, still the green area, have comprised more hospitalizations than all other pediatric age groups. Over the last 6 months, 25 to 30% of all COVID-19 associated hospitalizations among children and adolescents have been among these infants less than 6 months of age. Next slide. This figure shows the proportion of hospitalizations where COVID-19 is a likely reason for admission by age group and period of COVID variant predominance for June 2020 through November 2022. Reason for admission is determined by trained COVIDnet surveillance officers using an established algorithm. As a reminder, all COVIDnet hospitalizations have a lab-confirmed positive SARS-CoV-2 test during hospitalization or within 14 days before hospital admission. Hospitalizations where the admission is noted as likely due to trauma, obstetrics or labor and delivery, psychiatric admissions requiring acute medical care, and inpatient surgery or procedures are categorized as such. Hospitalizations where the chief complaint includes fever, respiratory illness, COVID-like illness, or suspicion for COVID-19 are classified as having COVID-19 as a likely reason for admission. Hospitalizations where the medical chart specifically indicates that COVID-19 was an incidental finding or that the admission was likely not COVID-related are also categorized as such. For hospitalizations where another reason for admission is specified in free text, COVIDnet clinicians examine the specified reasons and further classify. The chart displays the proportion of COVID-19 associated hospitalizations with COVID-19 as a likely reason for admission among 3 pediatric and 3 adult age groups, as well as overall by periods of variant predominance. As indicated by the set of columns second from the left, about 80 to 90% of COVID-19 associated hospitalizations among children ages less than 4 years had COVID-19 as a likely reason for admission across all variant periods. Older children, ages 5 to 11 years, ranged between 70 to 95%. Adolescents, ages 12 to 7 years, had the lowest proportion of hospitalizations with COVID-19 as a likely reason for admission, between 50 and 60% for the Omicron predominant periods beginning in December 2021. Among this group, many admissions are psychiatric admissions requiring acute medical care, with more than 25 or 35% of hospitalizations in some months. Adults ages 18 to 49 had a similarly low proportion of hospitalizations with COVID as a likely reason for admission, between 50 and 70% during the Omicron period. Among this group, many admissions are due to labor and delivery, with more than 25 or 30% of hospitalizations attributed to that in some months. Among adults ages 50 years and older, in the 2 rightmost set of columns, between 80 and 90% of hospitalizations have COVID as a likely reason for admission across all variant periods examined. Next slide. This chart describes the prevalence of underlying medical conditions among non-pregnant hospitalized adults ages 18 years and older, where COVID-19 is a likely reason for admission based on the definitions provided in the previous slide. Data are presented for June through November 2022, the most recent 6 months for which complete data are available. As indicated from left to right, the most common underlying medical conditions are chronic lung disease, cardiovascular disease, obesity, diabetes, and neurologic disorders. Chronic lung disease is prevalent in more than 2/3 of all adult COVID-19 associated hospitalizations, cardiovascular disease present in more than half, diabetes, obesity, and neurologic disorders in about 1/3, and renal disease in about 1/4. 96% of hospitalized adults have at least one underlying medical condition. Next slide, please. This chart describes the prevalence of underlying medical conditions in COVID-19 associated hospitalizations among children and adolescents ages 17 years and younger, again in June through November 2022, the most recent 6 months for which complete data are available. These data are limited to those hospitalizations where COVID-19 is a likely primary reason for admission. The most common underlying medical conditions are asthma, prematurity, feeding tube dependence, and obesity. It's important to note that asthma and prematurity are underlying medical conditions in more than 10% of these pediatric cases. In contrast to adults, 49% of COVID-19 associated hospitalizations among children and adolescents have no recorded underlying medical conditions. Next slide, please. This chart further describes the prevalence of underlying medical conditions by pediatric age group, where COVID-19 is a likely reason for admission. There are some notable differences between younger and older pediatric age groups. Among children less than 2 years of age, in the leftmost cluster of bars, prematurity, indicated by the orange bar, is by far the most common underlying condition recorded in nearly 20% of all hospitalizations. The next most common is feeding tube dependence at 5%, indicated by the gray bar. Among the three older pediatric age groups, the most common underlying medical conditions differ. While the order of these most common conditions vary by age group, the most common are asthma, feeding tube dependence, obesity, immunocompromising conditions, and chronic lung disease, not including asthma and not related to prematurity. Next slide. This figure shows the percentage of hospitalizations by vaccination status and age group for October and November 2022, the 2 months of data available after the updated bivalent booster dose was approved. More than half of hospitalized children ages 5 to 17 years were unvaccinated, as indicated by the orange portions of the columns. 1/3 of adults ages 18 to 49 years remain unvaccinated, and less than 25% for adults 50 years of age and older. Very small proportions of hospitalizations have been among persons vaccinated with the updated bivalent booster, as indicated by the yellow portions near the tops of the columns. Next slide, please. This figure displays age-adjusted rates of COVID-19 associated hospitalizations by vaccination status for adults ages 18 years and older from January 2021 through December 2022. The monthly rates among unvaccinated adults are depicted by the solid green line and were the highest of all vaccination status groups for every month. The purple line shows monthly rates of hospitalizations among adults who are vaccinated. The vaccination status depicted by the purple line changes over time as the vaccination recommendations and the status of the adults included in this group also changed over time, which is reflected by the different dashed line pattern in the purple line. The most recent data, most notably in November and December 2022, depicts rates of hospitalization among unvaccinated adults, the green line, adults who received the updated bivalent booster dose, the orange line, and all other adults who received at least a primary series of vaccine but had not received the updated bivalent booster dose, or the dotted purple line. In December 2022, compared to adults who received an updated bivalent booster dose, the monthly rates of hospitalization were 16 times higher among unvaccinated adults and 2.6 times higher among vaccinated adults who had not received an updated bivalent booster dose. Next slide. I wanted to acknowledge all the folks who helped the enormous amount of data that goes into these portions of the presentations, including my colleagues on the ResNet team, as well as many others in Corvid, our ResNet partners, as well as state, local, and territory health department partners. And I hope these data are seen as helpful, and I'm happy to take any questions. Thank you.
Thank you very much, Dr. Taylor. This presentation is now open for questions. Dr. Paling.
All right. Thank you, Dr. Taylor, for this tremendous presentation and for your entire team. You did show a ton of data. I really appreciated your last slide about the monthly adjusted rates of hospitalization by vaccination status for adults. And my question is, I do recognize that the pediatric recommendations have not been as long, but do you have a similar slide for children? Thank you.
Thank you. So these data from this slide are posted publicly. The figure that I showed again for adults is age adjusted. I included that one because that one has the data on the bivalent booster dose. We have a quality standard for the COVID-net data where a certain proportion of the underlying COVID-19 catchment population has to reach a level of vaccination in order for our rates to be considered stable. And our most recent data that we have analyzed, the pediatric groups have not yet reached that standard for us to be able to include them. We hope with the data that we just received a few days ago, that we'll be able to start displaying those data. So the data that are posted, we have sort of the pre updated booster dose categories of unvaccinated as well as vaccinated plus or minus a booster dose. But we have not yet been able to display the data showing the rates among those that have received the updated bivalent booster dose.
Ms. McNally?
Thank you. I really think that this slide highlights for us the importance of continuing to think about how to encourage vaccine acceptance. And I want to say that having the countermeasure injury compensation program working well is an important part to vaccine acceptance. And so I want to encourage the expeditious review of claims made as it relates to vaccination and the continued development of an injury table as you're working through these issues. Thank you.
Thank you for that comment, Ms. McNally, a really important one. Dr. Long.
I'm wondering how you're thinking about this still 16-fold higher hospitalization rate in unvaccinated with the current transmissibility of coronavirus and the likelihood that what percentage of adults have had a first infection. You'd think they'd act more like vaccinated, maybe not boosted or vaccinated. So how are you thinking about this retention of 16-fold higher, and what do we think are the current seroprevalence rates in adults of natural infection?
That's a great question. I appreciate that. I can't speak immediately to the seroprevalence. We do know, and we've discussed within our team, it's, because we are looking, obviously these rates among the unvaccinated folks are higher, but we also do know that, that there is immunity provided by infection. And so we aren't able to adjust for that. We have the vaccination status, but with at-home test and a variety of other data sources, we're not able to include prior infection into this figure, into the data. But that is a limitation, and it's one that as more people got vaccinated, especially in some of the older groups where there's very high levels of vaccination, we know that it's hard to say for certain exactly what this means with diminishing numbers of adults who remain unvaccinated. And so I don't have a solution, but it is something that we recognize as being very important. And as we continue to collect these data, it's something that we have to reckon with as more and more people become vaccinated, potentially with one potential way of looking at this in the future is doing it in a seasonal way. So perhaps not ever unvaccinated, but unvaccinated for that particular season. That might be one way to look at that. That is not necessarily the way we're going to go, but that is a potential option if patterns for COVID vaccination recommendations mirror those more closely like something we see for influenza.
Dr. Daley.
Yeah, I want to jump in here. I guess when I look at this, I assume that the bulk of the unvaccinated have been infected. And so then this to me indicates that prior infection doesn't give you much immunity. It gives you some, but is it short lasting, or it's only against the variant that you were exposed to? And so, I mean, I think I would be, I think we want to, if the data supports it, we want to be clear with the message that prior infection is not adequate for protection against future hospitalization from COVID.
Dr. Lehrer?
Thank you. Could we go to slide 7, please? I regularly have patients and even colleagues who sort of say, well, they don't quite trust the hospitalization data because lots of people are being hospitalized with COVID for other reasons. But if my interpretation of what you're showing here is for the over 65-year-olds, for everyone who was hospitalized and had COVID during the hospitalization, over 90% of those admissions were related as the primary likely reason for admission was COVID. So they weren't just COVID incidental, they were admitted because of COVID. Is that an accurate interpretation?
Yes, based on our algorithm, that is correct. I will add that this can be a conservative algorithm, but we're actually doing a more expansive analysis, looking at this more closely from a couple different angles, looking at treatment, looking at primary and secondary ICD-10-CM diagnosis codes, in addition to this algorithm with the data provided through the medical abstraction of the abstraction of the medical chart. But yes, and you can see those patterns for the older adults as well as for the very young children.
Dr. Peeling?
I really appreciated slides 8 and 9 talking about the underlying medical conditions. And if I am understanding Dr. Cotton correctly, I believe 3% of the U.S. population is immunocompromised, and that increases with age. And we can see there is a significant disproportionate hospitalizations among the immunocompromised, both in children and adults. And that is really important and highlights the importance of timely vaccination among all. Thank you.
I see Dr. Kane's hand is raised.
Yes. For the very last slide that was shown, do you have that hospitalizations broken down by race?
No, we don't. We have race for the hospitalizations, but we don't have race for the underlying for the underlying population race by vaccination status. That's complete enough to be able to provide reliably.
So I was trying to emphasize the point that Kathy just made just recently, that when you look at chronic conditions, it is at a much higher rate in African Americans and even diabetes with Latinos. And so I wondered how that impacted hospitalizations, but also it would help us determine, am I 18 to 24-year-olds who are unvaccinated less likely to be hospitalized because they're healthier than, say, someone that is 65 and older, when I'm seeing all this very high vaccination status? So should that mean I should be focusing a lot of my resources on a younger age group over the age of 18, maybe to 35? But it clearly, if it's broken down by race, I suspect we're going to continue to see twice the rate of hospitalizations in African Americans and Latinos. And if you're Native Americans, maybe even 4 times that rate of hospitalization. I'm just trying to see if that trend is continuing since last year.
Yes, so while we can't show the rates by vaccination status, we do track rates by, while we can't show the rates by vaccination status by race and ethnicity, we do show, publicly we post the general hospitalization rates by race and ethnicity, and it does show, again, overall, we're not powered to show, unfortunately, rates by age, by race ethnicity. But the overall rates, we do see those patterns that you mentioned, where obviously there are differences within groups. And that's something, and actually we have a publication in that we've submitted now looking further at COVID-19 data by race and ethnicity, because it is so important, and we've seen these differences since the beginning of the pandemic, and it's important to continue to describe them in the ways that we're able to.
Thank you.
Thank you.
Thank you. We'll move on to the next. I unmuted the wrong one. We'll move on to the next presentation by Dr. Amadea Britton, who will provide updates to COVID-19 vaccine effectiveness in the U.S.
All right, good morning. Today I'll be presenting a summary of vaccine effectiveness data available from CDC studies, including vaccine effectiveness of both the original monovalent vaccines and updated bivalent vaccines. I will first present estimates of vaccine effectiveness, or VE, of monovalent vaccines for symptomatic infection in young children. I will then present an update on VE of bivalent vaccines against symptomatic infection for children and adolescents aged 5 to 17 years and adults aged 18 years and older. Finally, I will provide an update on VE of bivalent vaccines against severe disease with the focus on adults 65 and older. I will start by presenting data on VE against symptomatic infection in young children aged 6 months to 5 years for Moderna and 6 months to 4 years for Pfizer-BioNTech, as presented in last week's MMWR. First, I would like to orient everyone to the current recommendations. For children 6 months to 5 years receiving Moderna, the recommended primary series is 2 doses given 4 to 8 weeks apart. Given that dosing interval and the initial authorization date of June 18th, 2022, August 1st was the earliest date that a child could have been included in analyses for the complete series. In other words, the earliest a child receiving the vaccine could have been at least 2 weeks after completion of their second dose. For children 6 months to 4 years receiving the Pfizer-BioNTech vaccine, the recommended primary series is 3 doses, with the first and second doses separated by 3 to 8 weeks, and the second and third doses separated by at least 8 weeks. Since this series required an extra dose, the earliest date a child could have been included in analyses of the complete primary series was September 19th, 2022. For Pfizer, the recommended third dose was changed from a monovalent to a bivalent dose on December 9th, but this analysis was restricted to VE of monovalent doses because uptake of the bivalent dose in this age group remains too low at this time to estimate VE. For background, I'm sharing here the national coverage estimates from CDC's COVID data tracker for the primary series among young children, shown in the red box. Note that young children have the lowest coverage for either a single dose or a completed primary series, with just over 10% for 1 dose and just over 5% for the complete primary series in children aged 2 to 4 years. Coverage is even lower among those under age 2. Children vaccinated early may be meaningfully different than those who remain unvaccinated, which may impact VE estimates. These estimates should therefore be considered preliminary. The ICAP platform includes community-based testing data from pharmacies and partners nationwide. It uses a test-negative design with self-reported vaccine history at the time of test registration. For this analysis, only children whose caregivers reported symptoms and who were between the ages of 3 and 5 for the Moderna analysis and 3 and 4 for the Pfizer-BioNTech analysis were included. Children with immunocompromising conditions were excluded. Data are presented here for tests from July 4th, 2022 through February 5th of 2023, although the analysis start date varies depending on the dose analyzed. This was a period when the Omicron BA4 and BA5 sublineages predominated, but includes some time when XBB and related sublineages were circulating. Here we see preliminary estimates of VE against symptomatic infection for monovalent Moderna vaccine among children 3 to 5 years. In the red box on the top, we see a VE of 40% for one dose or a partial series during the interval between the first and second dose. In the red box on the bottom is VE for the complete 2-dose primary series of Moderna, with a VE of 60% during the 2 weeks to 2 months after the second dose. This decreases to 36% after 3 to 4 months, though the confidence interval was wide and has some overlap with the earlier estimate. Here we see the same graphs, this time for Pfizer-BioNTech in children aged 3 to 4 years. In the first red box, for a 1-dose partial series, we see a VE of 19% with a confidence interval that just crosses the null. For 2 doses, which for Pfizer is also a partial series, VE was 48% in the interval between doses 2 and 3. For 3 doses, the complete Pfizer primary series, VE was 31% in the 2 weeks to 4 months after the dose. There are a number of limitations for this analysis. First, as noted earlier, vaccine coverage is low in children 5 and under. When coverage is low, vaccinated children may be meaningfully different than unvaccinated children, potentially biasing early VE estimates and making the estimates less stable over time. Second, the prevalence of prior infection among children is high. Based on CDC seroprevalence data through December of 2022, more than 87% of children aged 6 months to 4 years old have had a prior infection. If unvaccinated children have protection from prior infection, it may lead to underestimation of VE. However, as the prevalence of prior infection is so high, these estimates are likely to represent the current situation among young children in the United States. Lastly, while the goal of the U.S. COVID-19 vaccination program is to prevent severe disease and hospitalization, the ICAP platform estimates VE for symptomatic infection only. Low vaccination coverage in this age group has to date prevented estimation of VE against more severe disease in other platforms and may impact future ability to estimate VE in this age group, including against severe outcomes. Given this context, VE against symptomatic infection can provide important insight into vaccine protection. In summary, a complete monovalent primary vaccination series helped provide protection for children aged 3 to 5 years against symptomatic SARS-CoV-2 infection for at least the first 4 months after vaccination. Some waning of the monovalent Moderna primary series might occur by 3 to 4 months after the second dose based on point estimates, although confidence intervals overlapped. This is similar to patterns observed in older children and adults in the first months after vaccination. Waning of monovalent Pfizer-BioNTech VE against symptomatic infection could not be assessed, but is also likely based on analyses in older children and adults. CDC recommends that children should stay up to date with COVID-19 vaccines, including completing the primary series, and those who are eligible should receive a bivalent vaccine dose. We will continue to monitor VE in this age group, including against severe disease and for recently authorized bivalent doses. I will now move on to present updated estimates of VE for a bivalent booster dose against symptomatic infection in children and adolescents aged 5 to 17 and adults aged 18 years and older. Before I present these data, I would like to review the concepts of absolute and relative vaccine effectiveness. Absolute VE compares the frequency of health outcomes in vaccinated and unvaccinated people, such as comparing outcomes in people who received an updated bivalent booster versus no vaccine at all. Relative VE compares the frequency of health outcomes in people who received one type of vaccine to people who received a different vaccine, or by comparing people who received more vaccine doses to those who received fewer doses. For example, comparing outcomes in people vaccinated with an updated bivalent booster versus monovalent vaccine only. In the analyses presented today, relative vaccine effectiveness can be interpreted as the additional protection provided by an updated bivalent booster among people who already received monovalent COVID-19 vaccines. Now moving on to the analysis. This is again using the National Pharmacy Testing data through ICAT. The red box highlights the differences between the methods for this analysis and what was previously shown for younger children. Here we're looking at children and adolescents aged 5 to 17 years and adults 18 and older with COVID-like illness. Individuals with the last monovalent dose less than 4 months ago were excluded. Persons with immunocompromising conditions were also excluded. Tests in this analysis were completed between December 1st, 2022 and February 13th, 2023. This includes periods of both BA5-related sublineage predominance and of XBB and XBB.1.5 related sublineage predominance. Because previously published work from this platform demonstrated that VE against symptomatic disease for these two groups was similar, we have combined these time periods. And here are the results for relative VE for children and adolescents aged 5 to 17. On the left, I show age group and vaccine dosage pattern, including the reference group, which received 2 or 3 monovalent doses and no bivalent dose. And then those who are 2 weeks to 1 month, 2 to 3 months, and for 12 to 17-year-olds, 4 to 5 months since a bivalent booster dose. What we see is that relative VE in the month after vaccination is 65% for 5 to 11-year-olds and 68% for 12 to 17-year-olds, with an early indication of slight waning as was observed with the monovalent vaccine. Please note that a Pfizer-BioNTech bivalent booster was first authorized for adolescents 12 and older on September 1st and for children 5 to 11 on October 12th of 2022. Moderna was authorized for children and adolescents 6 to 17 on October 12th as well. This means that there is less follow-up time for children aged 5 to 11 years, and we were therefore not able to estimate VE 4 to 5 months after the bivalent dose in the 5 to 11-year-old age group. This slide shows the same analysis, but for adult age groups, with individuals that received a bivalent booster compared to individuals that only received 2 to 4 doses of monovalent vaccine. We observed similar waning patterns across age groups. In the red box, I have highlighted the estimates among adults 65 and older, which appear slightly lower than in younger individuals. The pattern of waning against symptomatic infection is very similar to what was observed after monovalent booster doses, with VE against symptomatic infection decreasing to minimal protection by around 5 to 6 months. Now moving on to updated estimates of bivalent VE against emergency department and urgent care encounters and hospitalizations in adults 18 and older from the VISION network. The VISION network is a multi-state network based on electronic health records. Like ICAT, it uses a test-negative design with cases having COVID-like illness and a positive PCR, and controls having COVID-like illness with a negative PCR. VE is adjusted for age, sex, race, ethnicity, geographic region, calendar time, and local rates of SARS-CoV-2 circulation. Vaccination is determined via electronic health records and state and city registries. On this slide, I show estimates of absolute VE of 2 to 4 monovalent doses versus being unvaccinated against both ED-UC encounters and hospitalizations stratified into the age groups 18 to 64 years and those 65 and older. It is important to note that the median time since last monovalent dose, highlighted in the red box in the third column on the table, is almost a full year for both age groups. What we observe is that residual protection against ED and UC encounters, shown here, is minimal for both age groups. However, it remains a bit higher against hospitalization, with residual protection of 19% for those 18 to 64 and 28% for those 65 and older. Understanding that there is likely some residual protection from monovalent vaccines against hospitalization is important context to understand the relative contributions of bivalent vaccines shown on the next slide. We also observe that protection appears slightly higher for both outcomes in those 65 and older, which may be due to behavioral differences and lower infection-induced immunity among older individuals. Now on this slide, we show relative VE of of the bivalent booster against ED-UC visits and hospitalizations. The reference groups here are the individuals from the prior slide who received only monovalent doses, with their last dose at least 2 months ago. Note again that most individuals in this group are almost a full year from their last dose. In the top red box are the ED-UC estimates. Among these individuals, a bivalent booster offered an additional 50% protection against ED-UC visits in the first 7 to 59 days after boosting, which declined to 36% after 60 days, with the median time since dose 76 days. Relative VE against hospitalization, shown in the lower red box, was similar at 52% and 31% at 7 to 59 and 60 to 119 days, respectively. Please note that although the relative trends are similar for both outcomes, residual protection prior to the booster was higher against hospitalization than for ED-UC visits, and so likely total protection against hospitalization is also higher. There may also be some hospitalizations captured by the VISION platform that represent less severe COVID-19 disease comparable to that of an ED or UC visit. I'll now provide an update on data published by CDC in December looking at the effectiveness of the bivalent boosters against hospitalization in adults 65 years and older through the IV network. The IV network is a multi-state VE platform that uses a prospective test-negative design. For this analysis, participants were from 24 hospitals in 19 states, with hospitalization between September 8th of 2022 and January 30th of 2023. Note that this analysis includes data beyond what was published in the MMWR in December. Participants included in this analysis were adults 65 and older hospitalized with COVID-like illness. Cases have a SARS-CoV-2 positive PCR or antigen test, and controls are negative for SARS-CoV-2 and influenza by PCR. Models are adjusted for age, sex, race and ethnicity, admission date, and HHS region. And here we have the updated IB results among adults aged 65 and older. On the left-hand side of this slide is the dosage pattern studied. We'll start first with the upper section of the slide, which shows absolute VE against hospitalization for adults 65 and older, comparing people with at least 2 monovalent doses but no bivalent dose to unvaccinated people. This result is displayed in the upper red box and shows VE of 17% with a confidence interval crossing the null, consistent with limited to no residual protection. The second estimate displayed in the lower red box is relative VE of a bivalent booster comparing individuals that received a bivalent booster with individuals with at least 2 monovalent doses but no booster. The additional protection offered by a bivalent booster is 52%. Note that the median time since last dose is almost a year at 352 days. Lastly, I'm now displaying absolute bivalent VE at the bottom of the slide. This is comparing individuals that received a bivalent booster to unvaccinated individuals, i.e. people that never received even monovalent vaccine. This estimate is almost identical to the relative VE of the bivalent booster from the line above, which is consistent with the finding that the monovalent vaccine is providing limited to no protection after 1 year. Here I would like to briefly share some information on the COVID-19 hospitalizations included in this analysis. As a reminder, all cases included in the analysis met the COVID-like illness definition. Patients with incidentally detected SARS-CoV-2 infections with no COVID-like illness were not included. Note here, however, that of all included cases, 59% had hypoxemia or low oxygen levels, and 16% required ICU level care. This suggests that, as with VISION, there may have been some cases included that, while a result of COVID-19 disease, did not represent severe COVID-19 disease. Inclusion of less severe cases may result in lower estimates of VE against hospitalization, as we know that VE tends to be higher against more severe outcomes. Oh, I apologize, I didn't advance the slide. This is the slide this was relevant to. Okay. I will now conclude by discussing some limitations for the data on older children, adolescents, and adults, and summarize key points for these populations. There are several potential limitations. First, estimates of absolute vaccine effectiveness. If unvaccinated individuals are meaningfully different than vaccinated individuals, these estimates may be biased. Second, for interpretation of estimates of relative vaccine effectiveness, residual protection from prior doses is an important consideration. This is likely to be particularly important for severe disease, for which residual protection from prior doses may be higher than protection for symptomatic infection. In addition, interpreting waning relative VE for bivalent doses is challenging because relative estimates are also dependent on the underlying patterns of waning protection of prior monovalent doses. This means that if relative VE decreases, it does not necessarily mean the total protection an individual experiences has decreased by that same amount. Third, we have limited information on prior infection, although just as with young children, we know rates of prior infection in adults and older children are high. VE estimates presented today are therefore a snapshot of how well the vaccine is working under current conditions. Lastly, VE against COVID-19 associated hospitalization from the platforms presented today represents COVID-19 disease requiring hospitalization but may underestimate protection against more severe disease, such as that requiring respiratory support and ICU level care. In summary, current data from CDC vaccine effectiveness platforms demonstrates that bivalent booster doses provide added protection compared to earlier monovalent doses against symptomatic infection in children and adolescents aged 5 to 17 years and in adults 18 years and older, though there may be early evidence of waning, consistent with patterns previously observed for monovalent vaccines against symptomatic disease. Updates to VE of bivalent booster doses against ED-UC visits and hospitalization in adults confirm that the bivalent vaccines are providing protection against ED-UC visits and hospitalization compared to people who received 2, 3, or 4 doses of the monovalent vaccine and no bivalent dose. For most people who received monovalent doses and are eligible for a bivalent booster, more than a year has elapsed since their last monovalent dose, and they may have limited remaining protection. All eligible people should stay up to date on COVID-19 vaccinations, including receiving a primary series and a bivalent dose if eligible. That concludes this presentation. I would like to thank the numerous individuals and teams, both at CDC and at platform study sites, for their countless hours ensuring high-quality data and analyses are available for ACIP to review. Thank you.
Thank you very much. And this presentation is now open for questions. Dr. Paling.
Dr. Britton, I want to say thank you. You have presented a tremendous amount of data, and I also recognize that you're making sure that there's confidence and sufficient data to make estimates. And I appreciate the data you were able to show on symptomatic infection in children. I hope that in the future, when there's sufficient data, that we could see the emergency department and urgent care, as well as the hospitalizations in children, and recognize that their vaccination recommendations came later, so that data is probably going to lag, but that will be important for the future. Thank you.
Thank you, Dr. Paling. Are there any other questions about this presentation? Oh, did you want to comment? Sorry.
I'm just going to say that's definitely a high priority, and we are checking every available avenue. So,
Dr. Kane?
Based on the data that you showed, will this have any implications for in the future, how frequently we add an additional booster dose, like the flu shots we're given once a year annually? Can we give this booster, the bivalent, once a year based on this waning effectiveness? Any suggestions, recommendations?
Thank you for that question, Dr. Kane. Actually, you are prescient in that will be part of the conversation we will be having in moments. So if you could just hold that question. Thank you.
Thank you. Okay.
Okay, I don't see any additional hands raised. Thank you very much for updating us on that data. It was excellent. And I, like Dr. Paling, also appreciated seeing the positive impact on symptomatic infection in children. Okay, next we have Dr. Sara Oliver, back to you. We're to provide considerations for transitioning to a bivalent primary series. After that, we will have time for discussion. So, Dr. Oliver.
Thank you so much. And yes, happy to say that the second presentation I have deals with future thinking and frequency of dosing. For this presentation, we'll talk about considerations for a bivalent primary series. Next slide. So for this, we're specifically asking for ACIP thoughts on harmonizing the vaccine strain composition for mRNA COVID-19 vaccines across both primary series and booster doses. For now, what that would logistically mean would be changing the primary series from the monovalent vaccine with the ancestral or original strain to bivalent with the ancestral and BA.4/5 strains for all ages. To further explain, on the left is a simplified representation of current recommendation, where for most of the population, we have a 2-dose primary series that's a monovalent vaccine and a bivalent booster. On the right, what we're proposing is future recommendations where all vaccines are bivalent. I'll note that for a later presentation, we're going to talk about simplifying this primary series and booster approach for some ages. But for this presentation, we're specifically discussing using our existing vaccine framework, just potentially using a bivalent vaccine for all recommended doses. Next slide. Policy on any bivalent primary series will be coordinated with FDA for regulatory action and CDC for recommendations for use. Today's discussions are pre-decisional, and there will not be a vote specifically on this. Next slide. So first, to summarize the public health problem. Next slide. This slide shows the current U.S. vaccine coverage by dose and by age. As this discussion is focused on the primary series, the eligible persons would be those who are unvaccinated currently. Then, as is highlighted in this bottom row, that is predominantly children or a pediatric population. So we'll focus on this, the next several slides specifically around children. Next slide. This is a slide from the previous COVID-19 presentation highlighting hospitalization rates in the pediatric population. While the highest rates are among children less than 6 months of age, hospitalization rates have varied over the last several years, with an increase during that larger BA.1 Omicron surge in early 2022, especially among children 6 months through 2 years of age. Next slide. Then again, a slide from COVID-19 as well, highlighting underlying medical conditions in the pediatric population. So half of hospitalized children had no underlying medical conditions. Next slide. Then these are the slides that show COVID-19 hospitalizations by vaccination status. On the left is in green for children ages 5 through 11 years, and on the right in blue for adolescents 12 through 17. Across all ages and through the time frame shown, hospitalization rates were higher for unvaccinated children and adolescents. As was discussed earlier in the presentation in the COVID-19 discussion, given low uptake of the bivalent boosters in this pediatric population, they aren't yet able to estimate hospitalization rates for children and adolescents with a bivalent booster. However, just back one more slide, sorry. But you can still see that the lowest hospitalization rates are among the vaccinated individuals, and hopefully data in coming months will be able to include the bivalent population. Next slide. So here we show COVID-19 deaths in children and adolescents by year of age over the course of the pandemic. Over 1,500 children have died from COVID since early 2020, with the highest numbers of death in the youngest children and in older adolescents. Next slide. Then this slide shows death rates by vaccination status for everyone ages 5 and over. While we can't limit this analysis to just the pediatric population at this time, you can see that the lowest rates of death are among those with the updated or bivalent booster. Next slide. Some summary for this: children and adolescents can develop severe COVID. While the rates in children are lower than adults, nearly 1,500 children and adolescents have died from COVID since the beginning of the pandemic. And we can't predict which children will have severe disease. Half of the hospitalized children and adolescents had no underlying medical condition. During all time periods, COVID hospitalizations and mortality were consistently higher among unvaccinated persons than among persons who'd completed a primary series and/or an updated booster. However, in spite of this, many children remain unvaccinated for COVID. Next slide. So now we'll walk through data on benefits and harms. Next slide. So the available data to evaluate a bivalent vaccine as a primary series is available for Moderna using their BA.1 bivalent vaccine, given as a primary series to children 6 months through 5 years of age. These data were presented at VRPAC last month and we'll summarize here today. There were 179 children who received a 25 microgram bivalent vaccine and were compared to nearly 5,000 children who received a monovalent ancestral vaccine previously. The median follow-up time for the two groups varied slightly. For the original ancestral vaccine, the follow-up time was just over 100 days, whereas for the bivalent vaccine, it was 85 days. And then this is an important note, the two studies were done at two very different time frames, so the seropositivity of the participants is quite different. For the study with the original vaccine, 8% of those children were baseline SARS-CoV-2 seropositive. Among children who received a bivalent primary series, over 60% were baseline seropositive, likely reflecting the impact of Omicron and infections over the past year. Next slide. So this slide compares the immunogenicity of the original monovalent vaccine and the BA.1 bivalent vaccine. The top rows compared geometric mean titers for the BA.1 neutralizing antibodies for bivalent compared to monovalent, with a ratio of 25 highlighted in the box. This clearly met the pre-specified superiority criteria. Then the lower rows show antibody titers to the original strain. The BA.1 bivalent vaccine provided a boost, but the ratio was below 1. However, the ratio of 0.83 did meet the pre-specified non-inferiority criteria with a lower bound of the confidence interval of 0.667. Next slide. Then for the available safety data of a bivalent primary series, there were 142 children who received both doses and were included in the safety analysis. Overall, the percentage of patients reporting a solicited local or systemic event was similar to or less than percentages seen after the original vaccine. However, this may be a result of the larger seropositive participants in that bivalent group. The next two slides we'll go over this in a little bit more detail, but the adverse events seen after a bivalent primary series were very similar to what was reported after the original vaccine in this age group. No grade 4 solicited adverse events were reported. There was one serious adverse event of asthma exacerbation after the first dose that was assessed as unrelated to vaccination by the investigator. Next slide. So this slide shows local reactions for the BA.1 bivalent vaccine in green compared to the original vaccine in blue. Again, rates were the same or lower in the bivalent group, and injection site pain was the most common local reaction. Next slide. This slide shows systemic reactions for children 6 through 36 months on the left and 37 months through 5 years on the right. Again, similar patterns were seen overall, with irritability is the most common in the younger children and fatigue in the older children. Next slide. Then as we think through other considerations for a bivalent primary series, we just wanted to address some concerns around imprinting. As a reminder, imprinting is the concern that the initial exposure to one virus strain may prime the B cell memory and limit the development of memory B cells and neutralizing antibodies against new strains. As we now have 3 years of experience with this virus, we have learned that prior infection and/or vaccination history likely has some impact on the subsequent immune response. We know that the risk of reinfection can vary by somebody's previous infection or exposure. This can be impacted by a variety of factors: continued virus evolution of SARS-CoV-2, time since last vaccination or prior infection, and possibly imprinting. But we also know that affinity maturation can occur. This is the ability of memory B cells to mature over time, especially when exposed to newer strains. Affinity maturation is also likely improved with more time between doses. And while somewhat limited, several studies have shown that a variant-specific vaccines can not only boost, but initiate new variant-specific immune responses. However, most of these studies are focused on lab-based assays. The clinical impact of any of this, the different immune responses by prior exposure, and how it may differ by vaccination and infection requires additional research. What we do know is that vaccines continue to be able to provide a broad boost in antibody response and continue to provide important protection against severe COVID. It's also important to note that the concerns around imprinting are not if people can develop an immune response after these bivalent vaccines, but what exactly is the incremental benefit of an updated variant-specific vaccine. Next slide. So for the next two slides, we'll review the available data we have that compare the monovalent and bivalent vaccines. We've already reviewed the only data we have that look at this for a primary series. So the next two studies look at what we have for boosters. Several studies compared antibody titers with recent Omicron sublineages for both the bivalent and monovalent vaccines. Studies ranged from around 21 to 42 days after the bivalent vaccine. I will say there's a slide at the end of this presentation that provides additional data, including the specific antibody levels. So this is a bit of a simplification of a lot of research, but there's a slide there if you want a deeper dive. For this interpretation, so assays differ by lab, and the exact level of titers can't be compared across different labs. The most meaningful outcome for this is the ratio of antibody titers from bivalent to monovalent vaccines. So that's what we've shown in the figure. A ratio of 1, which is highlighted with the red line, would mean the two vaccines are equal. A ratio of over 1 would mean an improvement with a bivalent vaccine, and a ratio of less than 1 would be better titers in the monovalent vaccine. The figure also differentiates by type of assay done. So on the left, the studies done with a pseudovirus neutralizing assay have green text, and the live virus neutralization assays have a blue text. The bars are also slightly different shades of blue based on which Omicron sublineage was tested. BA.4/5 is in the lighter blue, and the XBB is shown in a darker blue. Overall, most studies show an improvement in neutralizing antibodies for Omicron sublineages with a BA.4/5 bivalent vaccine, where that ratio would be over 1. There are differences noted in the ratios of type of assays, where the improvement in the bivalent vaccine seemed to be more noted when the assay was the live virus assay. However, the clinical impact is unknown for any specific ratio or antibody level. As we all know, neutralizing antibodies at a single point in time can't convey the entirety of the immune response. Next slide. So this slide highlights the clinical data we have to compare outcomes for monovalent and bivalent vaccines. We're unable to do head-to-head studies comparing clinical outcomes directly in the US due to timing of the authorizations. However, these data were shown at VRBPAC last month and are in a preprint that's listed below. A study in the UK found around 10% increase in relative vaccine effectiveness for the prevention of COVID infections for a bivalent BA.1 vaccine. However, no COVID hospitalizations were noted at the time, so they're unable to estimate the differential impact for the prevention of severe COVID. Next slide. So overall, bivalent COVID-19 vaccines are able to induce an immune response when given either as a primary series or as a booster. There are limited data to directly compare COVID-19 outcomes after receipt of a monovalent or bivalent vaccine, especially against the prevention of severe disease. But we do continue to know that COVID-19 vaccines have a high degree of safety. Initial safety data from a bivalent primary series trial are encouraging, but the study wasn't powered to assess rare adverse events. Next slide. Now, just briefly to highlight some feasibility and implementation considerations with a transition to a bivalent primary series. Next slide. This slide shows representations for the number of mRNA COVID-19 vaccine products currently between monovalent and bivalent, as well as different doses and formulations by age. Next slide. While the final number of products will ultimately depend on what is authorized, these are what is possible with transitioning from primary series to bivalent. We could be down to 5 total products. And importantly, it would eliminate lookalike vials for Pfizer and Moderna. Next slide. So overall, a transition to a bivalent primary series could improve storage space. Providers have limited storage space, and as we move to the use of a VFC program in the future, it's worth noting that VFC stock is required to be duplicate and separate. It could also reduce errors, again by eliminating lookalike vials, as well as currently one of the most common administration errors reported right now is providers giving a bivalent vaccine as a primary series dose in error. It would also allow for continued access to primary series. While the dates vary by product and age group, the majority of our current monovalent vaccine stock in the US expires within the next few months. There would be a possibility that access to primary series could be more limited without transitioning to a bivalent option. Next slide. Then just a quick note on resource use. Work is ongoing to evaluate cost effectiveness in preparation for transition to commercialization of COVID-19 vaccines. However, for this particular question, bivalent vaccines are already purchased, delivered, and available. Transition of a primary series recommendation from monovalent to bivalent is unlikely to have a significant impact on resource use. Next slide. Next slide. So in summary, receiving a COVID-19 vaccine primary series continues to be important for the prevention of COVID-19 severe disease, hospitalization, and death. However, in spite of this, many children and adolescents remain unvaccinated for COVID. COVID vaccine recommendations that are simple to implement may remove some barriers to uptake. Harmonizing the primary series and booster doses could simplify the presentation, reduce administration errors, and allow for continued access to primary series for unvaccinated populations. And overall, when discussed with the work group was supportive of this transition of the mRNA COVID-19 vaccine primary series from monovalent to bivalent. Next slide. Just want to thank everyone again. There is a team of unsung heroes, I like that, behind any of the slides we show. Next slide. So this is for the discussion. We'd love to get feedback from ACIP on this issue. However, I do want to just provide 2 quick clarifications before we totally open it up. Again, a transition to bivalent primary series can only occur after FDA regulatory action and updates to CDC recommendations. There's no vote, it's pre-decisional, but ACIP's discussions can help inform actions for the future. And in addition, while we have used monovalent and bivalent designations based on the currently available products, the discussion isn't necessarily that the primary series would be bivalent or this exact vaccine in perpetuity. We know that there's the possibility that there could be updates for strains in COVID-19 vaccines. This has been discussed at VRPAC. For future vaccines, really the focus is on harmonizing what we offer for a primary series and what we offer for booster. With all that said, the question to ACIP is, what are your thoughts on a transition of the mRNA COVID-19 vaccine series from monovalent to bivalent? Thanks.
Thank you so much, Dr. Oliver. And while my colleagues are thinking about some of the questions related to what's on the slide, I actually wanted to take a pause and go backwards a little bit, in part because we are fortunate to have Dr. Grimes on the line specific to the CICP and VICP compensation program. So, Ms. McNally, would you mind just repeating the question you had from earlier? And thank you, Dr. Grimes, for being willing to stay on.
Dr. Grimes, thank you so much for joining us today, and thank you for your update yesterday regarding the CICP claims regarding COVID-19 measures. I think it's really important for the public to know that your numbers that you reported yesterday are available on your website, and that my comment really related to the fact that I think that vaccine acceptance is so critical, and I think that the CICP processing of claims expeditiously is important and encourages vaccine acceptance. So I wondered if you might be able to give us an update on the vaccine injury table, and if you could please explain to the public why it takes time to develop that table. I think that's really important. Thank you.
Yes, thank you. So as you know, the Countermeasures Injury Compensation Program provides compensation for covered serious injuries and deaths that are based on compelling, reliable, valid medical and scientific evidence found to be directly caused by the administration or use of a covered countermeasure. So in the case of COVID-19, that would include COVID-19 vaccines. We wholeheartedly agree. The expeditious processing of claims is of paramount importance. We have had a large volume of claims submitted to the CICP, over 11,000 alleged COVID-19 countermeasures. Over 8,000 of those are COVID-19 vaccine related. We have been processing claims as expeditiously as possible and fully agree that we'll continue that effort moving forward. For the CICP, we promulgate countermeasures injury tables. Those countermeasure injury tables for a serious physical injury to be added to a countermeasures injury table, it also must meet the compelling, reliable, valid medical and scientific evidence. And those have to go through federal rulemaking to be promulgated. So that is a bit of a timely process. Vaccine injury table is specific to our National Vaccine Injury Compensation Program, or the VICP, which is a separate process that currently does not cover COVID-19 vaccines.
Thank you so much, Dr. Grimes.
Thank you. We'll do Dr. Paling and then Dr. Cotton.
All right. Thank you, Dr. Oliver, and to all of your team and persons that contributed to all the information available in these slides. I really appreciate the very systematic approach, sharing all the data that's currently available as this conversation is being debated by the FDA. To answer your question, I am in support of harmonization. And the reason for that is, in talking to my pediatric and family medicine colleagues, as well as for other vaccinators throughout the state, the number of doses in the refrigerator and the lookalikes are a major source of safety concerns. And so simplification will improve the logistics, the feasibility, and the confidence of families in receiving the vaccine. The second thing I'm hearing is that families are having a hard time understanding why you're recommending a bivalent vaccine for the adult and telling them that their young child needs 2 doses of monovalent before they can receive a bivalent. And that has been a very confusing message. And then moving to a bivalent would be an easier communication. It would also improve safety, in my view. Thank you.
Thank you. Dr. Cotton?
Thank you for all of the information you presented. This has been an ongoing issue because it's not been easy for people to find monovalent. I was wondering if you had any comments or if the group had considered what this would mean for people who have, say, undergone CAR T-cell therapy or bone marrow transplant, in whom a full repeat vaccination series is recommended. And would we now switch all of that to bivalent, which seems reasonable, but I was wondering if you had further comments on that specific topic for immunocompromised patients. Thank you.
Thanks, Dr. Cotton. I would say, so for very specific points like that, we'll have to ultimately kind of defer, work with FDA on language that's in that's ultimately in the authorizations. But I think overall, writ large, the concept of, for anybody who needs a primary series, really for whatever reason that may be, it would be that bivalent product, that we wouldn't need to keep monovalent products stocked really for kind of any of the indications for a primary series. But what I will say is, if when this occurs, we'll update the interim clinical considerations with a variety of those details.
Thank you.
Thank you. And one of our colleagues from FDA, if you're able to comment on when you might anticipate it would be possible to transition to a BLA, and I ask because, two options are in front of us. One is to continue to modify the authorizations for very special cases, or the second would be to allow clinicians to have the ability to prescribe as they think it makes clinical sense to do so. Dr. Kessler, are you on the line?
Yes, this is David Kaslow. I'm Office Director here for Vaccines Research. Yes, we are working this topic very diligently and are trying to move towards this as quickly as we can, but I probably can't say any more than that at this time.
Thank you, Dr. Kaslow. We appreciate you being on. Dr. Long.
Tagging on to Dr. Paling's comments about it being positive about the bivalent being pushed back to the primary series because of difficulties in safety and administering different vaccines at different ages. I would like to just speak a little bit to the new disease of coronavirus in young infants and children. You know, not only does this virus have a miraculous ability to change and escape immune protection, it also has changed its stripes in the age groups affected, but also in the clinical diseases. So I haven't seen that adolescent with an ARDS kind of picture of coronavirus as we saw at the beginning of the pandemic in quite a while. We have those older children in intensive care units who are medically complex and are on some kind of respiratory support or tracheostomies and things at home. But then we have this big cadre of younger children who have coronavirus and either high fever and seizures or fever, don't know why, or this winter, lots of coronavirus plus bacterial mastoiditis, bacterial tracheitis with group A strep and Staph aureus, bacterial pneumonia with necrotizing pneumonia. So there is an urgency, and this is undoubtedly Omicron in these children. And so there's an urgency for these bivalent vaccines, these newer strain vaccines, to be available for primary series in children down to at least 6 months.
Thank you for weighing in, Dr. Long. I just want to make sure that if there are other opinions the ACIP committee members would like to express regarding the two questions on this slide. As a reminder, we're not having a vote. This is a discussion, but it would be really helpful to get on record if you have particular thoughts about these two questions. In the meantime, I'm going to ask Dr. Dries if she would ask her question.
Great, thank you, Dr. Oliver, for a great talk, as always. And I just wanted, though you focused on children aging in to requiring primary series, the other population I'd like to remind the committee of is our new healthcare workers, either people that are just graduating from their program or people that are moving from a non-healthcare role, such as like in environmental services, to a healthcare role. And we're also seeing some difficulty in people finding vaccine. And again, healthcare workers are still required by CMS to at least have a primary series. And so that is causing some consternation and delay in bringing on new healthcare workers when they can't find the monovalent vaccine. So certainly Shay, I think, would be in full support of this transition, or at the very least, some flexibility in allowing the bivalent vaccine to serve as the primary series. Thank you.
Thank you. Dr. Sanchez is next. Because I think our members have had a very long 3 days, I'm also just going to ask if you have any thoughts about the question, sorry, not two questions, question on the slide, and also if there's any other thoughts for why it wouldn't be a good idea. It would actually be really helpful to hear that as well. Dr. Sanchez.
Thank you, and thank you, Dr. Oliver. I think it makes sense to move towards a bivalent, and because that, and I imagine that that for future vaccines, I'm sure there will be new compositions that will need to be studied because, already, we've seen a new variant than what is in the current bivalent. But I think it makes sense towards to transition to bivalent primary series. I'd like to see some data on the Moderna study. I was wondering if Pfizer has similar data, and as we harmonize will a primary series with Pfizer continue to be 3 doses versus Moderna 2, and so I'd like to see a little bit more concrete data, or what future recommendations may be.
Thanks, Dr. Sanchez. I will say we have colleagues from Pfizer on the line. Dr. Kane, I don't know if there's others from Pfizer who want to.
Thank you, Dr. Oliver. We have Dr. Sharu from the RU, our research unit, to address that question. Sharu, are you connected?
I am. Can you hear me?
Yes.
Perfect. Thank you. So I very much appreciate that question. We are, as discussed at VRPAC, currently enrolling in our dose finding portion of a primary bivalent series with the bivalent Omicron BA.4/5. And we're looking towards having data a little later in the fall. As you've noted in these discussions, there's actually been low uptake, and we're reflecting that also in our clinical trial as well in terms of enrollment. Regarding your question of the 3-dose primary series and a simplification, that would really require FDA guidance, and I would defer back to Dr. Kozlow on the next steps to allow for that.
Can you comment, though, with the current study that you're doing, is it a 3-dose schedule?
Of course. Thank you so much. Yes, we are working as per the currently authorized vaccine on a 3-dose primary series. The phase 1 includes children 6 months to less than 2-year-olds and the 2 to 5-year-old age group, with 90 participants in both of those groups for a total of 180. And we're dose finding with 3, 6, and 10 micrograms currently. Did I answer your question, Dr. Sanchez?
Dr. Daley.
Oh, Dr. Daley. Oh, I'm sorry.
Yeah, thanks so much, Dr. Oliver. To look at this specific question, I'm in support of transition from a monovalent to a bivalent primary series. I think, Dr. Lee, you asked, is there any discussion of a downside of this transition? And I think we would all say, so I'm going to state the obvious, which is if there was any evidence that it was less safe or there was any evidence that it was less effective, then we would make a different decision. And I think I'm going to echo Dr. Bell I hope she doesn't mind, but Dr. Bell has said, this is the decision for today. And I think this is an entirely reasonable decision for today. I think it just highlights how important it is that we have such strong and active and intensive monitoring of vaccine effectiveness over time, because I think what we need to do first is encourage vaccination with a primary series across the entire population, including the pediatric population. And then when achieving that, then we will have a better ability to assess vaccine effectiveness. I think we need to recognize that the bivalent vaccines have half as much mRNA for strain A and strain B, and we just need to know, is that adequate protection over time? To do that, we need all the systems in place humming and working in a synergistic way, and I have the confidence that they will, but I just want to highlight that this is the decision for today, and we need that continued vigilance around safety and vaccine effectiveness to continue to make good decisions. Thank you.
Thank you, Dr. Daley. Dr. Long?
I think the other advantage of the transition, again, in pediatrics would be we would have another chance to educate pediatricians and parents. This is a different vaccine. This is a different day. These are different risks, because I think the current vaccines that are available for young children have been mainly taken advantage of by educated and advantaged people who really want their children to be able to go to daycare and school so they can go to work, rather than people who are thinking, my child is at risk of a serious disease because of coronavirus. And that's not true anymore. And so we have the opportunity to take this in a sidebar that children need this vaccine and they need this new one because this new virus is a risk for children. So we have to sort of do disclaimers about what previously coronavirus did not do to young children.
Thank you. Dr. Brooks?
Yes, thank you. So in reflecting on the whole day, we started with the information with the safety monitoring. And that gives me more confidence in saying that I concur with the transition to a bivalent. As we move forward, we will have more experience, but we also will be monitoring the safety. I think what Dr. Daley said, the reasons not to do it be a safety concern and an efficacy concern. I don't think we should underestimate the importance of simplification from 11 to 5 vials. Vaccines don't save lives, vaccination does. And so to get it simpler for the pediatricians, and maybe as we get to it, the pharmacists, to vaccinate, I think it's important. I think it was interesting. I'm not sure if Dr. Daley said about the less MRI per subtypes, per lineage of the bivalent, but I'm also thinking about that B cell maturation. So I am wondering if you have two, if you will, lines of B cells and you can see maturation over time, will that be helpful as we look toward new strains? I mean, by the time this comes out, it won't even be, it's not even now BA.4/5 or the original. So I'm thinking that perhaps a bivalent may actually be somewhat more protective in terms of giving cross protection. And then lastly, I know Pfizer is saying that they're going to do a 3-dose primary series. It would harmonize even more if biologically speaking, there could be a 2-dose Pfizer series, but that's just kind of leave that on the aside. Thank you.
Thank you, Dr. Brooks. Dr. Dries, is your hand still raised?
Oops, I'm sorry, I forgot to put it down.
Thank you. Dr. Duchin?
Thank you. Jeff Duchin, Infectious Diseases Society of America. This is not a question specific to the transition question. It might be more appropriate for the future directions discussion, so feel free to defer till that time. But my question is, are there any considerations or ongoing discussions around increasing the dosing interval in the context of new recommendations and or taking into account a history of past infection? Thank you.
Thanks. I will take you up on postponing that discussion until after we move. I think we do have some timing of doses discussion in the next presentation. Thanks.
Dr. Sanchez.
No, and along with that, I think we have to recognize that a lot of the data that's been presented, including as we look at bivalent dose, is that we're dealing with a predominantly previously infected population. And the seroprevalence rates are so high that that even the data on hospitalization, et cetera, both vaccinated and unvaccinated, is very likely that many of them have had prior infection. And we know that the studies show that natural infection with vaccination actually is optimal immunity. So I just want to comment on that. We cannot forget that a lot of these discussions are in a highly previously immune population. Thanks.
Thank you. Dr. Saneas, I know your audio is in and out. Are you able to hear us and chime in?
I can hear you, and I will try to chime in. I just also wanted to voice my support for harmonizing the primary series with the booster vaccines for all the reasons that have been previously stated, including simplicity, access, and the potential for reduction of errors.
Thank you so much, Dr. Sineas.
Thank you.
Dr. Long.
So one of the things is we try to simplify all this, and I don't know about, we still have to talk about a future, but looking at the crystal ball about the future, everybody would like to make this an annual event or maybe a semi-annual event for some seniors. But I am increasingly concerned because of things like we heard earlier, that maybe there was a signal, took a while to figure it out, whether there really was or wasn't a signal, in concurrent immunizations, in concurrent vaccines. And maybe we learned something about that that's new for influenza vaccine, that influenza vaccine standalone maybe has a certain safety profile. And maybe influenza concurrently administered with this and that has a different safety profile. And maybe it's not a new vaccine that has a concern of a safety profile or a signal or a potential signal. So it strikes me that sometimes in our want to be getting everyone vaccinated and doing it all at once, that especially with new products, we really don't have more than minor immunogenicity data that it might be okay to give this concurrently with something else. But as we pile more vaccines into what we hope will be a platform for adults for immunization, this causes me concern for safety problems that we don't anticipate, safety problems with older vaccines, and not being able to know what we need to know when we recommend the schedule.
Thank you, Dr. Long. So as part of the discussion we'll have a little bit later, but I wanted to maybe state what you're thinking in a different way, which is that, there's two things. One is I tend to be a more pragmatic person, and I think it's, as was pointed out multiple times, it would be, we have made this vaccination schedule so complicated for our frontline providers that it becomes so difficult to even give, even if you want to do the right thing and you have the kid in your office. So I have a strong request and plea for simplification, so that is why I am supportive of this transition. At the same time, I do feel like my request to our industry colleagues as well as the FDA is that I do think having additional data would help with vaccine confidence. And that actually is something that I feel will not only provide confidence around the data itself, but give us the ability to be able to reflect on that and then translate that to a broader population. So I, was hearing a trial size of 90, which might be sufficient for the particular endpoints. But what I would ask is that as FDA is reviewing and as our industry colleagues are developing these trials, that they're thinking about the end goal, which is really to support confidence in the safety and the effectiveness of these vaccines. And while we often have to use indirect measures, being able to articulate our confidence in that entire process would help us as we're making these decisions. So my hope also is for more data, but I really think it's not because I it's because I really want to be able to support a meaningful, effective, and safe vaccination program, and all of us have that same goal. So we hope that this plea will go a long way. All right, I don't see any other hands raised for now, so why don't we break for 10 minutes, and we'll be back at 50 minutes after the hour. Thank you, everyone. We'll now reconvene the ACIP meeting. At the start of this meeting, I am looking at Dr. Romero to give him an opportunity to make a brief statement before we move on to the next set of conversations. Dr. Romero.
Thank you, Dr. Lee. So before the committee begins the next series of presentations, I want to take a moment to reinforce the importance of the Advisory Committee on Immunizations Practices input as we plan for the future use of COVID vaccines and potential updates to the nation's COVID-19 vaccination efforts. These initial discussions by you, the ACIP voting members, and its liaisons are happening at a time when there is still limited data and several unanswered questions. However, it's essential that your discussions not be paralyzed by these uncertainties and limitations. The information previously and to be presented to you will allow you to assess what is now several years of viral and vaccine data. Nevertheless, it is important that we acknowledge multiple uncertainties and unknowns that exist. Hopefully, the information presented will begin to help you plan for the best path forward when it comes to the use of our available COVID-19 vaccines. CDC is encouraged to hear of your support for tentative plans to harmonize COVID-19 vaccine efforts and shift from the original monovalent primary vaccine formulation to a formulation used for updated bivalent boosters. While this would not happen until the appropriate FDA authorizations, it's clear that concurrence on a single vaccine composition for primary and booster doses would help streamline and simplify CDC's recommendations, reduce complexity, and allow for clearer communication and guidance to healthcare providers and to the public. CDC recognizes that the previous 3 years have been very difficult for the ACIP as they have crafted their recommendations. I know this firsthand, having occupied a seat at the inner table during the initial 18 months of the SARS-CoV-2 pandemic. You have often been asked to make difficult decisions without all the information that you would have desired in order to quickly respond to this evolving and unprecedented global pandemic and public health emergency. This has led to the crafting of incremental vaccine policies that have at times added complexity to our COVID-19 vaccinations and schedules. Despite the previously mentioned challenges, you have helped shape vaccine policies that have ultimately helped protect millions of people across the United States and save millions of lives. CDC and the American public are grateful for your contributions and your leadership. CDC remains committed to the efforts to ensure optimal vaccine recommendations as we move forward. CDC will continue to monitor the SARS-CoV-2 evolution, COVID-19 disease levels, and vaccine safety and effectiveness in the months ahead. I and the CDC look forward to hearing your thoughts and insights this afternoon as you discuss the future direction of COVID-19 vaccine program and potential updated recommendations for this fall. Thank you very much.
Thank you very much for those comments, Dr. Romero. We will now move on to Dr. Megan Wallace, who will be speaking about the benefit and risk assessment for COVID-19 vaccines. Dr. Wallace.
Thank you, Dr. Lee. Good afternoon. Next slide, please. In this presentation, I will first show the benefits of COVID-19 vaccine by age for the primary series. Then I will present the incremental benefits of COVID-19 vaccine by age and time since last dose for a bivalent booster dose, with sensitivity analyses modeling high and low points in the pandemic. And finally, I will present the benefit risk assessment for the bivalent booster dose, focused on ages 12 to 17 years and 18 to 49 years. Next. I want to begin by reviewing the methods we used. We performed the assessment for both primary series and bivalent booster with the results presented per million primary series or per million bivalent booster doses. We use the COVID-19 associated hospitalization rates from December, which were the most recently available rates by vaccination status, but we also use sensitivity analyses to model high and low points in the pandemic. Our time horizon, or the period over which we allow benefits of vaccination to accrue, was 6 months. We use the vaccine effectiveness estimates from Vision with the assumption of waning by 10% each month starting after month 2. VE for the primary series assessment was based on the absolute VE for a bivalent dose, and the VE for the bivalent booster assessment was based on the relative VE by interval from last monovalent dose to bivalent dose. Next. On this slide, we are looking at the monthly rates of COVID-19 associated hospitalization by vaccination status from COVID-net, which is the main driver of these assessments. The green line is the rate among the unvaccinated, which is the basis of our primary series assessment. The blue line is the rate among the vaccinated, which is the basis of our bivalent booster assessment. As I mentioned on the previous slide, both assessments use the December rates, which are the rates shown on the far right of the figure. We showed the overall age-adjusted rates here for simplicity, but if you look in the table on the right side of the slide, as we all know, there are considerable differences in the hospitalization rates by age group. Next slide, please. This slide shows the estimated COVID-19 associated hospitalizations prevented for every million mRNA COVID-19 primary series. The bars show the number of hospitalizations prevented over a 6-month period, with the rows representing different age groups. As you can see, there are still significant benefits to primary series vaccination. The benefits are the most striking in the older adults, with nearly 16,000 hospitalizations prevented per million doses given. But even for children, we see nearly 250 hospitalizations prevented per million doses given. Next. Now on this slide, for those age groups for which there were sufficient data, we've added the benefits of the bivalent booster, represented by the blue bars, which are again the estimated hospitalizations prevented per million doses over 6 months. These are the additional benefits one would expect from a bivalent booster beyond the benefits they are already receiving from any previous monovalent doses. Not surprisingly, the expected benefits are smaller for the bivalent booster than the primary series, but they are still substantial in the older adults, with nearly 2,500 hospitalizations prevented per million doses. However, for the adolescents, these numbers are smaller than what we've seen in the past, with an estimated 53 hospitalizations prevented in 12 to 17-year-olds per million doses over 6 months. Next. Dosing interval refers to the time between the most recent monovalent dose and a bivalent dose. This figure focuses only on the benefits of the bivalent booster doses, showing them by both age group and dose interval. The rows are still age groups, and the blue shading of the bars indicates the dosing interval, with darker shades representing longer intervals. We can see that dosing interval has a noticeable impact on the benefits, with longer intervals showing greater benefit. Next. Because benefits of a bivalent booster dose were smallest in the 12 to 17-year-old age group, and because the benefit assessment is so strongly impacted by hospitalization rates, we use sensitivity analyses to explore what our benefits would look like in this age group under different epidemiologic scenarios, focusing on the time since the Omicron surge. This figure shows the hospitalization rates in 12 to 17-year-olds by vaccination status. As we discussed before, the far right data point labeled as recent is what we used as our base case. We also calculated benefits from a low hospitalization rate scenario, which came from March 2022, and a high hospitalization rate scenario, which came from July 2022. For both the low and high scenario, we held the rate steady for the 6-month time horizon. Next. This slide shows the results of those sensitivity analyses, again focusing only on 12 to 17-year-olds. The rows are now the dosing intervals, and the shading indicates the incidence, with the lighter shade representing our low incidence scenario and the darker shade representing our high incidence scenario. As we can see, the benefits are driven strongly by hospitalization rates, but in what we are considering our high incidence setting, we would prevent around 120 hospitalizations per million doses over 6 months, depending on the dosing interval. Next. The dosing intervals have been different for monovalent and bivalent booster doses. Among adolescents who received a monovalent booster, nearly half received the monovalent booster at an interval less than 8 months after their primary series. Among those adolescents that received a bivalent booster dose, over 90% received it 8 months or more after their most recent monovalent dose. Next slide, please. We also want to consider the potential myocarditis risk following the bivalent booster dose in this age group. Right now, there are limited data to inform the myocarditis risk following a bivalent booster dose. Preliminary data from VSD have myocarditis rates following bivalent booster dose in adolescent males being lower than what was seen for the first booster dose, but this is limited by small numbers of doses administered. Myocarditis risk is lower with longer time between doses. We saw that rates of myocarditis were lower with an extended interval between dose 1 and dose 2 for the primary series. A longer interval between doses for bivalent boosters compared to monovalent boosters may also impact myocarditis rates. Most individuals with myocarditis or pericarditis have fully recovered at follow-up, and in previously published analyses, the risk of adverse cardiac outcomes were 1.8 to 5.6 times higher after SARS-CoV-2 infection than after mRNA COVID-19 vaccination among males ages 12 to 17 years. Next. This slide shows the myocarditis rates from VSD, shown in Dr. Shimabukuro's presentation earlier, by age and sex for dose 2 of the primary series, the monovalent booster dose, and the preliminary data for the bivalent booster dose. As you can see in the set of columns on the right, there have been few bivalent doses captured in VSD, but there has only been one myocarditis case reported in any of these age groups. And if you look at the incidence rates by dose, we see that the risk might be trending downward, with bivalent boosters having the lowest risk. But again, these are small numbers and wide confidence intervals. Next. This slide shows the Moderna myocarditis rates from VSD. Again, looking at the far right columns, there have been no myocarditis cases reported, but there have been few bivalent booster doses captured. Next. When we look at both the potential benefits and harms for adolescents together, using the hospitalization ranges from the sensitivity analyses, we see that per million doses we would expect to prevent between 31 and 136 hospitalizations, 9 to 40 ICU admissions, and 1 death. Based on the preliminary data on myocarditis following bivalent booster and VSD, we have seen 0 myocarditis cases in nearly 50,000 males that have received a bivalent booster dose, and no cases in females with a similar number of doses. I want to again stress that these are small numbers of doses, and though they correspond to a point estimate of 0 myocarditis cases per million doses, you can see in the footnote that the upper range of the 95% confidence interval runs from 0 to 62 cases per million doses. Next. On this slide, we have taken the results from the previous slide and applied a correction to account for the potential incidental SARS-CoV-2 infections among hospitalized patients that Dr. Taylor discussed in the COVIDnet presentation. After applying this correction, we estimate that per million doses over 6 months, we would expect to prevent between 17 and 75 hospitalizations, 5 to 22 ICU admissions, and potentially a death. Next. If we look at the benefit risk assessment for 18 to 49-year-olds per million doses over 6 months, we expect to prevent between 117 and 376 hospitalizations, 21 to 69 ICU admissions, and between 4 and 11 deaths. Among 18 to 39-year-olds in VSD, we have seen 1 myocarditis case in a male with over 180,000 bivalent booster doses given. No cases have been reported in females who have had even more doses recorded. And I know that 18 to 49 is a fairly wide age group for benefits, and unfortunately we aren't able to stratify it further for rates by vaccine status. But if we look at hospitalization rates overall, we see that 18 to 29-year-olds have lower rates than 30 to 49-year-olds, but higher rates than the adolescents. So the 18 to 29-year-old benefit risk would likely have lower numbers for benefits than what we see here, but probably still a bit higher than what we saw for adolescents. Next slide, please. And if we apply the correction for potential incidental SARS-CoV-2 infections among hospitalized patients, we estimate that between 81 and 259 hospitalizations, 15 to 48 ICU admissions, and between 3 and 8 deaths would be prevented. Next. There are several important limitations to the benefit risk assessment that should be noted. First, the benefits of vaccination may continue to accrue beyond the time horizon used. Stable hospitalization rates were assumed for the duration of the time horizon, which we know may not represent what will happen in the future. The underlying complexity of vaccine histories and previous infections could not be accounted for. COVID-19 hospitalization rates included hospitalizations for which COVID-19 was not a primary reason for admission. The extent to which COVID-19 hospitalization rates include incidental findings is the extent to which benefits may be overestimated. Current COVID-19 epidemiology reflects the impact of both prior vaccination and prior infection. We cannot account for possible future increases in COVID-19 hospitalization rates or a new variant. Myocarditis rates following bivalent booster dose are uncertain. Studies are underway to assess the long-term impact of vaccine-associated myocarditis. Next slide. In summary, significant benefit is still seen for primary series vaccination in all age groups. The benefits of a bivalent booster dose vary by age, time since last dose, and COVID-19 incidence. The risk of myocarditis after COVID-19 vaccines is likely reduced by a longer interval since last dose. Additional data can better define risk after bivalent vaccines, but current data are encouraging. Changes in COVID-19 hospitalization rates would impact the benefit assessment. There are additional benefits of COVID-19 vaccines unable to be quantified in the benefit risk assessment, including likely prevention of post-COVID conditions, possible reduction in transmission, and increased confidence in social interaction. The benefit risk assessment will continue to be monitored as new data are available. Receipt of primary series continues to be important in all ages, and boosters remain an important option to improve protection against severe COVID-19, especially for higher risk populations. Next. In closing, I want to thank all of those that made important contributions to this work, and in particular, Danny Mulia, who was integral. Next slide. Thank you.
Thank you so much, Dr. Wallace. Excellent presentation. This presentation is now open for questions. Dr. Paling.
Thank you, Dr. Wallace, for a great presentation and your team for pulling all this information together. It's very important and very clearly stating what the risks and benefits are. One of the questions I'd like to get clarification is for the COVID-net and COVID-19 associated hospitalizations, does that include the multi-inflammatory syndrome of childhood? Would that be captured?
Yes, I believe MISC is captured in those rates, although Dr. Taylor, if you're still on the line and would like to add anything.
I am, Megan. So we can capture them, but the data that are collected at the time of hospitalization. So we would only capture MISC if it was listed as an underlying medical condition, and we would not be able to capture MISC in COVID-net that was diagnosed after the hospitalization that it's included in the COVID-net.
Okay, so thank you for that clarification. So you are definitely capturing a fair number of cases of MISC, but it may be an underestimate, if anything, is my interpretation. I love this information. We know that MISC peaks in the younger children, so I do hope at some time we'll be able to see 5 to 11. The other thing that you talked about was one of the questions I get a lot is how much do I decrease my risk of MISC if I'm vaccinated? And I hope eventually we'll be able to answer that question, and same with long COVID for both children and adults. Thank you.
This is Chris Taylor again. I just wanted to add, I don't want to provide the impression that we capture a significant number. I don't have the numbers of cases that we have captured, but I just want to be clear that I'm not sure that I'm able to classify that as a significant number, as it's an underlying medical condition present at the time of hospitalization.
Okay, so then it could be a significant underestimate. Thank you.
Potentially.
And then I think we may, our VE experts may be able to provide, there is some information on VE against MISC.
Yes, there was actually an MMWR published about a year ago that looked at vaccine effectiveness of the primary series in children and adolescents against MISC, which did show high protective effect of primary series vaccination. Again, that was monovalent vaccination against MISC. And an article in August in Clinical Infectious Diseases we'd be happy to share, looking again at reduced likelihood of MISC in children ages 5 to 18 years of age, that primary series vaccination was associated with reduced likelihood of MISC in children 5 to 18 years of age as well.
Dr. Daley.
Yeah, thanks so much for that presentation, Dr. Wallace. Just a piece of context would be helpful for me, which is that I noticed you didn't provide updated risk benefit for folks over the age of 50 or 65. And is that because we don't think there's vaccine-associated myocarditis in that age group? Because I think the benefits are still worth sort of reiterating in this setting. Thank you.
Certainly, and you're right. We didn't focus on them for the benefit risk comparison because, you know, the risk is primarily in those younger age groups, and that's also the age group where the benefits are the smallest. But if we go to slide 7, we can see in the older age groups, you know, 50 to 64, 65 plus, you know, even depending on dosing interval, there's still pretty substantial benefits, but particularly in that 65 plus age group. I mean, they're pretty remarkable, you know, even for the bivalent booster, just the incremental benefit. We see, you know, 2,500 hospitalizations prevented, which is pretty substantial.
Dr. Duchin?
Thank you, Jeff Duchin, Infectious Disease Society of America. This was a fantastic presentation. Thank you very much. I just want to hit on one point, which I think is really important, and that is the priority that we should be giving to better understanding the spectrum and burden of post-COVID conditions in general, and incorporating them into information on the benefits and risks of COVID-19 vaccination. I think, you know, right now we know that there are diseases such as myocardial infarction, and we talked about stroke this morning, diabetes, neurological disease, other metabolic disease, long COVID, and so on, that we're not really measuring and capturing well and incorporating into our decision-making around a whole spectrum of COVID-19 prevention. So I just wanted to highlight the need for better data, and hopefully once that's available, we can use that to better understand the benefits of these vaccinations. Thank you.
Yes, thanks for that comment. And as certainly we reassess this pretty frequently, and as soon as data are available, we're always looking for ways to incorporate more things into the benefit risk. So I appreciate that and agree.
Thank you. I'm actually just going to second that. I do think there's a lot of work that needs to be done on past or long COVID, especially in children. But there are multiple federal efforts in this space, and so we appreciate, again, the continued collaboration across federal agencies to do this information sharing so that we can ensure that we are optimizing the benefit-risk balance. The only less, you know, so I really appreciate the overall summary and the summative statement that, you know, benefits continue to outweigh the risks for primary series in all age groups, I think is a really important one to emphasize. And to also continue to ask our committee to think through what else can we do to mitigate risk via the schedule? It's still a complex schedule, but as things start to simplify over time, it'll be helpful for us to think about those longer intervals, for example, as an important intervention that we are able to implement when either the context or the individual risk, i.e. immunocompromise, doesn't otherwise indicate a shorter interval. With that, I think we will move on. Is this truly the last session of the day? Dr. Oliver, okay, I can't believe it. All right. Dr. Sara Oliver will be presenting on COVID-19 considerations for future planning, after which we anticipate a robust discussion. Thank you, Dr. Oliver.
That's it. I'll present some slides and then you guys discuss the whole future. just that. Great, thank you so much. So for this presentation, we'll think through considerations for future planning for COVID vaccines. Next slide. So for planning purposes, we need to be aware and evaluate where we are now, and then identify and discuss where we're going. Next slide. And then obviously how we get there. Next slide. So as we flesh that out, we're going to review where we are now, including current recommendation, vaccination rates, and hospitalization rates for the program at large. Then as we think through where we're going, I think we've continued to say this today, but the goal is clear, simple recommendations. So as we think through how we get there, we have two questions we're going to focus on today. How frequently should people get a COVID vaccine? And are there groups or population who should potentially have more frequent COVID vaccines, such as more than one vaccine a year? We'll start first by reviewing where we are now. Next slide. These are our current recommendations for COVID vaccines. The point of this is not to review each individual recommendation, but that clearly the recommendations we have right now are complex. Next slide. Then we've showed this slide previously, but now I'm highlighting the uptake among the booster doses. Uptake is higher with older ages, but as you look, even uptake for the bivalent booster is only around 40% for those who are 65 and over. Next slide. Then this slide shows COVID vaccine delivery and uptake by age group. You can see that in general, uptake has declined as the number of doses recommended have progressed. But you can also see that people tend to get vaccinated in waves shortly after the recommendations. Next slide. So why is vaccine coverage lower than we may want? First, recent studies reflect profound COVID-19 vaccine message fatigue, COVID message fatigue for COVID mitigation measures, COVID vaccines, all of it. They reflect a desire to end the use of mitigation measures and a common perception that immunity is sufficient without future vaccine doses. We know there are other reasons as well. Barriers to vaccine access do still persist for some populations as well, including but certainly not limited to people who live in rural areas, people experiencing homelessness, and people with disabilities. We also know that despite improvements in vaccine equity after primary series vaccination that we saw with the incredible efforts in 2021 to get people vaccinated with a primary series, we've seen disparities in booster coverage that have emerged. Next slide. Then we also know that the virus continues to evolve. This slide shows recent variant proportions over time, with the recent surveillance estimating that nearly 3/4 of isolates may be projected to be XBB.1.5, which is in the darker purple here recently. Next slide. However, I think this curve is important as well. This is the estimated number of reported COVID cases by variant, so essentially combining the epi curves and the variant proportions. So you can see even with newer variants we've seen, we're not seeing the massive increases in cases like we did in the winter of 2021, 2022. Next slide. Then we're also in a period where most adults have had SARS-CoV-2 infection, vaccine, or both. The two bars on the far left show overall seroprevalence among adults from a study among U.S. blood donors, and only 6% at the top have had neither infection nor vaccine in these Q2 estimates of 2022. Next slide. Then this slide shows the overall hospitalization rates by age. We know the highest hospitalization rates continue to be among older adults. However, hospitalization rates among those less than 65 years have not mirrored the similar increases recently as they did earlier in the pandemic. Next slide. And then you've seen this slide previously, but we know that hospitalization rates are the lowest among those who've received a bivalent vaccine. Again, hospitalization rates were 16 times higher among unvaccinated compared to those who'd had a bivalent booster dose. Next slide. So just a summary of where we are now. Our current COVID vaccine recommendations are complex, and uptake of the current bivalent vaccines is low. The SARS-CoV-2 virus continues to evolve, but recent virus evolution has not led to large population-level surges in cases or hospitalizations. Most adults have prior infection, prior vaccination, or both. And hospitalization rates are highest in older adults, but remain low among people who've received a bivalent booster. Next slide. So now in thinking through how we get there, first we'll address question 1, how frequently should people get a COVID vaccine? Next slide. COVID cases are shown on the left figure and COVID hospitalizations are shown on the right. While our ability to capture COVID cases has changed over time with increasing utilization of the home antigen test, we continue to be able to closely monitor COVID hospitalizations. Then the winter months for the last 3 years are highlighted in the yellow boxes. We've seen increases in cases and hospitalizations either during the winter months due to development of a new immune escape variant, or unfortunately, as we saw during the BA.1 winter surge, when we have both. However, if you notice, this most recent winter did not have the increases seen for either of the previous 2 winters. Next slide. Then this figure shows VE against hospitalizations for the first part of 2022. The estimates have been shown to ACIP and are published previously, so the point of this is not the exact estimate. These aren't brand new. These are for the monovalent vaccines, but it's to point trends over time and with number of doses. So the green dot is 2-dose VE, the blue dots are 3 doses, and the black dots are estimates with 4 doses, again, all monovalent. With the monovalent COVID vaccines, we note that we've seen declines in VE over time since last dose. This is likely impacted by both time since vaccination and continued virus evolution. We do know that additional vaccine doses restored protection lost over time. While it's too soon to know the impact of waning in virus evolution on the VE of the bivalent vaccines over time, we're continuing to closely monitor and will bring any updates we have to ACIP. Next slide. So then this is VE against, with the bivalent vaccines. This is against hospitalization, again, looking at how VE varies by time since last dose. We know that this impacts the additional protection. The relative VE of bivalent boosters, again, as we've highlighted, meaning the additional benefits of the bivalent booster are higher the longer it's been since your prior monovalent dose. And as we discussed earlier today, safety is also likely improved with a longer time between doses, since the myocarditis risk appears lower with that longer interval. Next slide. So winter months and immune escape variants have impacted COVID epidemiology. However, this past winter did not see quite the same level of increases in cases or hospitalizations as previous winters. Time since last vaccine dose may both increase the incremental benefit of a COVID vaccine and decrease the risk of myocarditis. However, we do have to balance that with the fact that vaccine protection likely does decline over time. A plan for a fall booster dose this year could provide added protection at a time when many would be around 1 year from their last dose. And future epidemiology and SARS-CoV-2 virus evolution could help determine the need for continued annual boosters. Next slide. So now moving to populations who may need more than 1 dose a year. First, are there populations who still need a primary series in the future? While most adults have completed a primary series, most children 6 months through 4 years of age remain unvaccinated, as shown in the table here. For most older children, adults, adolescents, and adults, future doses will be an additional boost after prior infection, prior vaccination, or both. In addition, young children will continue to age into the vaccine recommendation at 6 months and could be SARS-CoV-2 naive. So because of this, there's likely some population of young children that still need a prime and a boost model to optimize immunity. Next slide. These data are from the excellent University of Iowa colleagues who've been able to conduct rapid surveys around intent. We know that while vaccination rates remain low in these youngest age group, there are still parents with intent to vaccinate their young child. For parents with an or under vaccinated child 6 to 23 months and 2 to 4 years, for both 38% said that they had an intent to get their child vaccinated in the next month or so. We also know that doctors' offices and clinics continue to be the most trusted place for parents to have their child receive a COVID vaccine. So thinking through optimal strategies for primary series vaccination in this young pediatric population continues to be important. Next slide. This slide is again from the COVIDNet presentation earlier, but we've highlighted here only children 6 months through 4 years of age to compare 6 months through 2 and 2 to 4 years of age. And you can see that pediatric hospitalization rates are higher among the 6 months to less than 2 years of age. Next slide. Then this slide shows pediatric seroprevalence, looking at infection-induced immunity on the left, and then combined infection plus vaccination-induced immunity on the right. We know that the youngest children, those 6 through 11 months, have the lowest both infection and combined immunity, and it increases with age of the child. Next slide. So as we think through a population that may still need a primary series, children less than 2 years have higher COVID hospitalization rates than older children. Children less than 4 years are less likely to have both prior infection and prior vaccination. We also know that children have frequent visits to healthcare providers. The AAP's recommended schedule for young children is on the right, and you can see that prior to 3 years of age, children are recommended to go to the pediatrician at least every 6 months, if not more, when they're younger. So the work group discussed continued primary series recommendation for young children. Both ages 6 months through 2 years and 6 months through 4 years were discussed without a clear consensus from the work group for either age cutoff. Without a clear cutoff from the data, the work group thought feasibility could also be considered as we think through this. Next slide. So the next population to talk about is older adults. This slide breaks out hospitalization rates in the adult population into a little more detail, and you can see that the highest hospitalization rates are among those 75 years of age and over, followed by those 65 to 74. Next slide. And then when we focus on COVID-associated hospitalization rates by vaccination status, you see similar patterns to what we've seen before. This is specifically looking at those 65 years and over. And again, hospitalization rates are the highest among unvaccinated, while rates among those who've received a bivalent booster continue to be low. Next slide. We know that immunity and vaccine response can be different in older adults. This is a slide from Dr. Britton's presentation earlier. While this is VE against symptomatic disease and not hospitalization, you can see that the patterns of vaccine effectiveness, including waning, may be different in older adults. However, waning for bivalent VE against hospitalization, including older adults, isn't yet known, but again, we're continuing to monitor. Next slide. So in summary, for this population, older adults have higher rates of hospitalization than younger adults, but the rates of vaccination among older adults who've already received their bivalent booster remain low. The work group emphasized the importance of older adults being up to date on current recommendations, including receiving a bivalent booster. The work group discussed more frequent COVID-19 vaccine doses for older adults, and at this time felt that the data were insufficient to determine a conclusion. The data weren't conclusive to yet identify a need for frequent vaccines, and there was concern that it may not be feasible to implement a vaccine program in all adults 65 and over twice a year. However, there was much discussion that these recommendations can be updated based on closely monitoring data in older adults, including hospitalization rates of older adults who've received a bivalent booster, bivalent VE and patterns of waning in older adults, as well as SARS-CoV-2 virus evolution and the possibility of future immune escape variants. Next slide. Then the final group to discuss, should people with immunocompromising conditions be recommended for more frequent vaccines? Numerous studies have demonstrated that mRNA COVID-19 vaccine effectiveness among immunocompromised persons is lower than that of immunocompetent persons, including within the period of Omicron. This has been demonstrated across a range of immunocompromising conditions, but is particularly notable for organ or stem cell transplant recipients. Then we also know we've previously had recommendations for different numbers of vaccine doses for these individuals. Prior to the bivalent booster dose, we allowed for up to 5 monovalent doses of COVID vaccine in this population. Vaccine effectiveness studies are not yet sufficiently powered to evaluate the effectiveness of a bivalent booster among persons with immunocompromise. Next slide. However, if we look at what we do know from monovalent vaccines, this figure's from a published paper, and I know that there's a lot of data points here, but the point is really to compare the VE among persons with an immunocompromising condition, which is in the red box, to people without immunocompromising conditions, which are the VE estimates above. And you can see that VE among immunocompromised persons is lower than that of immunocompetent persons at comparable time points after dose 2 and dose 3. And we also know that VE wanes in both immunocompetent and immunocompromised people. Next slide. So in summary for this population, immunocompromised adults can have a less robust immune response to COVID vaccines. And while not necessarily the scope of ACIP for now, it's important to note that there's not currently any authorized prophylactic monoclonal antibody products for these populations at higher risk of COVID-19. The work group discussed more frequent COVID-19 vaccine doses for people with immunocompromising conditions, and again at this time felt that the data were insufficient to determine a conclusion for definitive recommendations moving forward. However, the work group acknowledged that this population in particular may continue to be more vulnerable to severe COVID and likely needs flexibility with future COVID-19 vaccine recommendations. Next slide. So again, revisiting where we would like to go to the goal of simple recommendations. Next slide. COVID-19 vaccines continue to be the most effective tool we have to prevent serious illness, hospitalization, and death from COVID. The goal of the COVID-19 vaccine program continues to be prevention of severe disease, but we do know that prevention of post-COVID condition, increased confidence in social interactions, and even a temporary protection against symptomatic disease can be important as well. And as we've discussed throughout today, the benefits of an additional COVID-19 vaccine booster doses vary by age, by time since last dose, and by COVID incidence. We know that a simplified annual recommendation could help reduce vaccine and message fatigue, and a COVID vaccine framework that is similar to a well-understood influenza vaccine framework could be easy for COVID vaccine providers to implement and for the public to understand. Next slide. So for the overall work group thoughts on considerations for future planning, simple recommendations are easier to communicate, which also may improve uptake. The work group was very supportive of simplified recommendations and planning for future of COVID vaccines, which could also include additional updates to COVID vaccines in the future, as was discussed at the recent VRPAC meeting. However, uncertainties remain for the ideal timing and populations for future booster doses, especially if new immune escape variants develop. The work group was supportive of a fall or annual COVID vaccine program, at least for this year, with the flexibility to adjust based on new data, especially for populations at higher risk. The work group will continue to review data to inform future deliberations, vaccine effectiveness of bivalent vaccines over time, safety data of the bivalent vaccines, especially monitoring myocarditis rates as there are more doses administered, cost effectiveness analyses, COVID-19 epi, including hospitalization rates among the vaccinated and boosted people, SARS-CoV-2 genomic surveillance and virus evolution, and data from vaccine manufacturers as they continue to study these vaccines as well. Next slide. So again, acknowledging and thanking the team that helps pull all of this together. Next slide. So again, as we turn to the discussion, I want to emphasize that discussions for the future COVID vaccine recommendations are pre-decisional and are intended to inform planning and additional analyses. There's, again, no vote today, but it just will be helpful to hear ACIP thoughts as we plan for the future and continue to monitor the evolving situation. So we have three kind of specific questions that we would love to get thoughts from ACIP on. What does ACIP think about children who may still need a primary series? And then in particular, what age groups might that be best focused on? What does ACIP think about future recommendations for older adults? And what does ACIP think about future recommendations for people with immunocompromising conditions? Thanks.
Thank you, Dr. Oliver. That was excellent. And thank you for putting up the questions at the end. I was trying to remember them all as you were speaking, so I appreciate you putting it together. This presentation is open for questions. Dr. Lair.
Could you please clarify what you mean by think about children who may still need a primary series? I'm not sure exactly what you're asking.
Well, so I guess the work group agreed with the concept that, you know, there is a population that's going to continue to age in. There is likely to be an immune naive population that needs kind of still a prime boost. What the work group, it didn't feel like the data was completely clear and would love to get ACIP's thoughts on, is there a specific age group? So would we say for kids who've never had a COVID vaccine before, who are 6 months through 2 years of age, they need a primary series, and after that, they could get, you know, an annual booster dose. Similar to flu, like there is a population for flu if you've not had a flu shot before where you get 2 vaccines in your first series because you need the prime boost. So it's specifically saying, is there a population that we would really want to say, if you've not had a COVID vaccine before, you need a primary series, and what population that would be? So 6 months to 2 or 6 months to 4.
But wouldn't that be true for an 11-year-old or a 23-year-old who hasn't had a primary series who wants one?
Well, I mean, good question, and I think we can continue to discuss that. I think based on some of the seroprevalence rates, that has been a discussion that if we think it is likely that people, you know, children and adolescents have probably, based on the seroprevalence data, have likely been exposed, would we still recommend a multi-dose primary series in those populations in the future if we think, but happy to hear your thoughts on this. I think this is what we've been trying to discuss. Dr. Daley, I don't know if you might be able to say that slightly better than I did.
Well, no, I mean, I think, I don't know that I can say it better, but I can say it different. No, just that part of a conversation about who needs an annual booster is what to do about people who never received the primary series and where they fit in. And I think under this paradigm, which is not decided on, which we're here to discuss today, and problematically, we don't have a ton of data for. I think the idea is that a 18-year-old who's never gotten the primary series but has been infected and then gets a single dose in the fall probably has decent protection. We don't know that as established fact, but I think that's an assumption underlying this, that an 18-year-old might just get a single dose, and the recommendation would not be get 2 doses and then get an annual dose. So in other words, we're at a pivot point, and for those young adults who've never been vaccinated, probably they would just get a single annual dose and be considered up to date, quote unquote. Did I get that right, Dr. Oliver?
Yes.
Okay. I don't know who raised their hand first. Yeah. Dr. Sanchez.
No, thank you, Dr. Oliver. It seems to me that with respect to the question here, I think if, and that data should be available, that if, I don't care what age, even if the young child who's already had a documented SARS-CoV-2 infection likely doesn't need a primary series. And I think that I think that data should be available and can be looked at. So And I know that makes it a little bit more complicated rather than just say every child less than 5 should get a primary series. But I think if you've had a documented infection, you probably would just need a booster. Now, the other things, I also have a question. You don't mention pregnancy, pregnant women. And would you recommend, I think that's another population that needs to be looked at. Should every pregnant woman receive a COVID booster during each pregnancy to prevent not only infection in her, but also in the infant less than 6 months of age? So I think that that also should be brought to the work group and with the discussion. In terms of the timing, I just cannot imagine getting a COVID booster or more than once a year. I mean, if you want to simplify this scheme, I just cannot imagine that it can be even more frequent, even among the immunocompromised hosts after they've had their primary series. But I will leave it to Dr. Cotton if she's on the call, because that's her territory. And then we haven't heard anything about Novavax, and what is the scheme of things with Novavax in all of this? So there's a lot of questions there.
So first of all, thank you for your thoughts. I appreciate that. I will say, we have heard from some of our implementation-minded colleagues that having vaccine recommendations that differ based on prior SARS-CoV-2 testing would potentially be difficult to implement. I'm happy to hear from additional, if we think that that has changed, but I know that that has been, a continued discussion as we've discussed this on the work group. Then I specifically wanted to say something about your comment with pregnant individuals. I didn't include that here because we've not fundamentally had. This is more consistent with where we've kind of been with recommendations in the past. That would fundamentally be a little bit different. But I will say that that is one of the kind of top priorities for what we have for additional analyses to go moving forward, is to really do a deeper dive. I think we're getting emerging data on that and really look forward to kind of outlining all the available data we have to answer that question and to bring it to ACIP. So I think it wasn't included here because it's I think we need a separate, deeper dive on the data, but that is up on the docket for things for us to tackle next.
I see we do have colleagues from ACOG and ACNM on. It would be, if you are interested in, providing any comment of, where the organizations stand today, that would be really helpful.
This is Rhoda Sperling from ACOG. I think it's, the last comments were actually music to my ears, that a deeper dive is coming with information about pregnancy, because I think that is an important question about vaccination during pregnancy and what considerations are given.
Thank you. And Ms. Hayes?
Yes, Carol Hayes with the American College of Nurse Midwives. I think I have some concerns, and I would love to hear anybody else's understanding of this. But when we look at the bivalent vaccine and its ability to maintain a robust immune response, I'm thinking back to pertussis and whooping cough, and it was a vaccine that waned so quickly. We had to make that recommendation that every pregnant woman in every pregnancy get vaccinated, and we had a really hard time with uptake on that in the pregnant population. So I feel like we need data that says that if you want to protect your newborn, and that's really the message that we have to give, if you want to protect your newborn, you have to get vaccinated in every pregnancy. But we need a lot more data on what happens when you vaccinate a pregnant woman and how long does their immunity last.
Thank you both for providing comment. I'm going to move to Dr. Paling, and then we'll go to Dr. Cotton.
Okay, so I am thrilled we're having this conversation about pregnant and lactating women, because I think it is an essential conversation. And if I recall the data that we saw at the last meeting, we saw that COVID vaccine during pregnancy decreased your risk of preterm delivery, decreased your risk of being hospitalized and going to the ICU with respiratory problems, and decreased the risk.
To CC, two things. Just
1 second. Please go ahead.
And decrease the risk of low birth weight, decrease the risk of NICU hospitalization, and decrease the risk of hospitalization with COVID afterwards. So the benefits were profound, and seeing that over time is really important. I'm going to switch now and then talk about the children. And one of the components that I'm hearing to answer your question is that the message needs to Okay, does that sound right?
Now we can hear you.
Thank you.
Perfect.
All
thank
right,
you.
sorry, we unintentionally got muted. And so I wanted to talk about the children in the primary series. What I am hearing from families and community is that we need one message across the age groups. And so for me, I would like some data, and I do know we have colleagues that are doing all kinds of clinical trials, and I would like to know, I recognize you showed data showing the vast majority of older children have had COVID, and the seroprevalence is high. I would like to see a study saying, okay, you've just got one bivalent vaccine. What is the benefit and how long does that last? I think that would enhance the confidence in making a change rather than on inferring the data. And so for me, I would focus on all children. I do take care of immigrants and children that haven't been vaccinated across the age group. And that would be my suggestion. Thank you.
Thank you. Dr. Cotton?
Thank you very much for this excellent presentation and excellent discussion. We've certainly had a lot of questions about this topic, especially where many people had a dose of bivalent vaccine as early as last September. I will say that for the immunocompromised, the situation is much better than it has been. It's been a terrific journey with initially 3 doses of the primary series, followed by additional doses, and now the bivalent vaccine. And we are seeing much lower rates of severe disease. In fact, when we do see immunocompromised patients who are infected, we usually initiate antiviral treatment as soon as possible, and we are seeing very, very low rates, far less than 5% of severe disease in people who are immunocompromised, well vaccinated, and receive standard antiviral treatment. So things have really changed dramatically. And I would say that that's even in the setting of having lost the efficacy of the preventative monoclonal antibody Evusheld. So things have really changed, which is good. There are still many, many immunocompromised who have not taken the opportunity to get the bivalent vaccine. And I do think that from what I hear from patients, it's mostly just fatigue, and they thought that they were, 3 and done, and they sort of, it's a lot about the fatigue or not being fully aware of the opportunity. So the majority of immunocompromised patients I'm seeing are actually not up to date with their bivalent. So I would encourage anyone who hasn't had a bivalent to go ahead and get the bivalent vaccine. I do think that moving forward, I really like this idea about flexibility. And if the FDA decides that there can be some enhanced flexibility around recommendations, I think that that will be helpful. It has been really terrific over the course of the pandemic when we saw the disease rates were higher in immunocompromised. We were able to give, an additional dose of vaccine based on that. And so we will need to be responsive to upcoming increases in disease activity or viral strains, viral variants, et cetera. So I think flexibility will be key. So thank you very much for thinking of that. I do think that there are even special populations such as people who are older and immunocompromised. And for me, that's perhaps one of the highest risk populations. So I look forward to working on those populations together and seeing if perhaps they need annual or perhaps they need twice a year vaccination. I will say, with all due respect, Dr. Sanchez, I don't think that twice a year vaccine would be too challenging for many immunocompromised patients who really want to protect themselves. So from my perspective, that would be a reasonable approach, but I don't think we're there yet. And it's not clear that we need it based on the relatively low disease rates and certainly low severe disease rates that we are seeing in people who are currently up to date and well vaccinated by current recommendations. Thank you.
Thank you. Ms. McNally.
Thank you. Dr. Oliver, can you comment on whether or not the work group has discussed if there's a role for shared clinical decision-making, for example, in the older adult population or the people with immunocompromising conditions? And then my second question is there a concern that inequities would result if certain groups or populations were recommended to have more than one dose per year? Thank you.
Thank you. So yes, the work group has talked about populations that may benefit from a very strong recommendation and populations who may benefit from more of a permissive. And I think that is a little bit where some of that flexibility comes in. It may be hard. There are some populations where it's hard to make a population level where it's the same for everyone. Immunocompromised persons where their, timing of immunocompromising, their immune reconstitution could vary. So there's a variety. That and populations where that kind of benefit risk margin may be more narrow. So yes, nobody was comfortable. They felt like the data weren't quite there to propose like a structure for that yet. Acknowledging that there's still a lot of uncertainty with the epidemiology, with kind of the duration of what it looks like with the bivalent vaccines right now. And so I think there was an understanding that I think that strength of recommendation and flexibility could be something we could use in the future. The counter to that is we know simple recommendations are easy to communicate. And so we would not want, there's a balance there. And so I think the work group tries their best to balance both. And then as from an inequity standpoint, I will say that the work group really does try to think about that. We have some excellent kind of liaison members on the work group that try to make sure we're continuing to think through that. We've reviewed kind of inequities that exist currently with our bivalent vaccine recommendations as is, and so ways that we can improve those. I do think both the concept of simple recommendations that everyone can understand, as well as making sure that we remove barriers. We have heard that sometimes people get blamed for being vaccine hesitant when they're not vaccine hesitant. They just have barriers to actually getting the vaccine, and it's not fair to kind of blame them for being vaccine hesitant. So I think we need to look at that writ large for all of our recommendations moving forward. I'm looking. Dr. Evelyn Twentyman has helped us with a lot of our equity stuff, so I'm going to actually see if there's anything else she wants to say on that specifically, because I think it's an important point.
Thanks, Dr. Oliver. I agree with what you said, and I really appreciate the question. I wanted to add only that whenever our complexity of recommendations increase to the point of compromising delivery in any way through clinician frustration, through public COVID-19 message fatigue, it is those people with less strong access to our healthcare system as it is who will be affected, whether they want to get the vaccine or not. And so I think equity is actually quite wrapped up in this discussion today. Thank you so much for raising that.
Ms. Bata?
I think generally I'm in agreement with all of these three questions that we need to make sure that our naive children are getting a primary series. and that we may need to be watching our older adults. One of the things, the lingering question I have is related to the dosing for the bivalent and using that as a primary series. And I'm assuming, but I may be wrong, that we are moving into that dosing and comfortable because of the total amount of antigen the person gets through the vaccine, but also because of the seroprevalence that we're seeing among the population. And so that just may not be an issue, but it is something that I do have concerns about. And I think that what the work group has done and what our subject matter experts and team here at CDC has done has been remarkable in trying to address everything that's unknown. It's a moving goalpost for us. And so I want to commend everyone for this. And I think that that simplification is really important moving forward for the general public, because everyone's going, well, what now are they going to do? What now are they going to do? And I think that as we get more data, we are beginning to understand where we're headed. And I think this will be reassuring for the general public. Thank you.
Dr. Hogue? Dr. Hogue, can you hear us? Okay, we'll move to Dr. Kane.
Unmute myself. Hi. Infectious diseases adult.
Can you hear me now?
I think Dr. Hogue, I'll let him speak first. Okay. Yes, Dr. Hogue.
We don't hear you, Dr. Hogue, or I don't hear you. So, Dr. Kane, why don't you go ahead?
Okay, I'll just go on. So, and just a fabulous presentation. I really appreciated the data. I guess my concern is I'm thinking about the children now who may still need a primary series. We're seeing a huge influx of undocumented immigrants, populations who've never received a vaccination before. But in a prior data presentation, it showed that of the children that get hospitalized, 50% of them have no underlying medical conditions that we are aware of, but yet they're sick enough to be hospitalized. And so I wondered, is there any kind of context related to maybe food insecurity? Is nutrition impacting that? Or is it the environment that they live in, where there may be like post-traumatic stress that impacts immunity, things of that nature? Do we look at that in terms of who may be required to have that primary series? And if we get the bivalent primary series, do you really need a bivalent primary series and a booster that's bivalent? So can we cut down on the number of vaccines we're actually offering our children from so much antigen protection that we're providing them?
Thank you. So I will say I don't know that we have that level of kind of social factors for children, although that sounds like an excellent study. So if our academic partners are able to conduct that, we'd be more than happy to highlight those data at ACIP, because I think those are some very good questions. I'm actually going to use this opportunity. It is tangentially related to your question, but I think it's been a point. But so Dr. Jefferson Jones, who's pulling double duty, because I'll acknowledge he led a lot of RSV work yesterday, but he does excellent seroprevalence data for COVID. So he is on the line, and I think has a little bit of additional information he can say better than I can around some of the questions around COVID vaccine in children or in populations who had prior infection. Dr. Jones.
All right, can you hear me?
Yes.
Hi, this is Dr. Jones. So there is relatively little data in children, of course, compared with adults. And because many vaccine effectiveness platforms can have difficulty in identifying previous infection, particularly asymptomatic infection, a lot of the data comes from laboratory studies looking at those that had a known previous infection and that were subsequently vaccinated or had a breakthrough infection. And at least among those studies, many of those were early on in the pandemic, show after a vaccination, one dose of a vaccine led to neutralizing and binding antibodies that were at least as high, or if not higher, than those who received a primary series. So based on those laboratory studies, among those that have previously been infected, one dose of a vaccine appears to give at least as a robust a response as a primary series. And among vaccine effectiveness studies, again, the majority of which are in adults, they have shown that hybrid immunity it does give superior protection compared to just infection-induced immunity. And though infection-induced immunity does appear to give robust protection, particularly against severe disease, there is limited waning over a long amount of time. And it appears that there's less, I said, available, about one dose versus two in the vaccine effectiveness world, but the vaccination appears to increase or restore that immunity.
Thank you.
Thank you. I'm going to go to Dr. Hoag and then Dr. Lair.
Thank you. Can you hear me, Dr. Lee?
We can. Thank you.
Thanks so much. I apologize for that glitch in my technology. It's Michael Hoag with the American Pharmacists Association. First of all, I just want to say thank you to our CDC colleagues who are working tirelessly to get data out as quickly as possible. And I'm frankly just amazed at the work that CDC's staff and professionals and scientists perform, and I don't think you guys get enough credit for it. So I want to make sure that you are recognized appropriately during this forum. I want to speak to a couple of points that are inherent in the questions Dr. Oliver has asked. One is up to this point, of course, as we've moved quickly through the pandemic and we get new information and vaccines have come to market, we've had a somewhat rigid approval process through FDA for the vaccines that are there. And I think Dr. Cotton used the word flexibility, and I would like to recommend that that FDA and CDC going forward, as it specifically relates to people with immunocompromising conditions and perhaps the oldest of older adults, that there be flexibility. I think that the data only supports an annual booster at this point, but things change, as we know, with this virus. And so having language in the approval of whatever vaccine ends up being our bivalent formulation in the future that allows clinicians to make decisions based upon the latest epidemiology and transmission of disease and specific patient factors. I also think it's worth mentioning that there are individuals out there who are very much on top of their health. We've talked a lot about the people who are not getting immunized with the bivalent booster, but there are a lot of people out there who really are paying close attention and really want to make sure that they're as protected as possible because of their underlying conditions. And having that conversation on the front lines with their pharmacist or with their physician, we want those clinicians to be able to make good decisions for the individual patient based upon their comfort and desire, as long as we have safety in mind. And it's clear that we do, in fact, have a very safe vaccine with our bivalent vaccine. So I feel like that flexibility just needs to be put into this in some way with both older adults and people with immunocompromising conditions. The last just two comments. One is I would like to make an appeal to our pharmaceutical manufacturers who are producing these products that as we move into what appears to be a new phase of potentially annual boosters with the bivalent products, that you please be attentive to the presentation of your products, the labels, the colors of the vials, if single-dose syringes or single-dose vials across the board are possible. Frontline healthcare providers working in physicians' offices and pharmacies would be grateful for the least amount of confusion possible in those product presentations, and I hope that you will do so. The last comment is about minoritized communities, and equity is a major concern to me and to, I think, the pharmacy community. We know up to this point that Hispanic and Latino individuals in particular are more likely to get immunized in a pharmacy than they are in other points of care based upon some recent data. And we know that these recommendations are critical to follow as we go forward. And so I'm, again, simplification, very much in favor of that, but ensuring that we have access across all of our communities. Dr. Oliver, I will just bring up a question that I think Dr. Sanchez asked earlier, but I didn't hear the answer to, and that is, where does the Novavax product fit into all of this? I know there are a lot of pharmacists and physicians who have been asking questions about that product, and could you briefly just tell us where Novavax's product fits into all of this?
Thanks. I will say we were just saying that we need to make sure before at the end, we come back to that question. So happy to do it now. I will say that for right now, we were very intentional, especially in the last presentation when we talked about the transition from monovalent to bivalent. For the primary series, those discussions were focused on the mRNA vaccine. So for right now, no changes are anticipated. The primary series that is currently authorized and recommended for Novavax is monovalent, and it's our understanding that will continue to be available and recommended as is. I know there were discussions moving forward for the future of bivalent vaccines kind of across all manufacturers, including the protein subunit for future doses. And for that, I think we have Novavax colleagues on the line, so I don't know if they have a comment they want to make about planning for future as it relates to the Novavax vaccines.
Hi, this is Denny Kim. I'm the Chief Safety Officer for Novavax. I think, I don't think I have other colleagues on the line, so I'll chime in. Maybe I'll just give a second or two to see if there's some of my other colleagues. So not hearing anyone else, I will say I think you have that right. Is that we're in discussions with the FDA, and I think the next 2 to 3 months we'll get a lot more clarity on sort of the future directions going forward, both for the fall and winter campaign for 2023 and future vaccination regimens. But I can't offer much more clarity than that, other than that we are in active discussions with the FDA.
Okay, thank you, Dr. Lair.
So to answer your specific questions about my thoughts on these questions on the board, I would like to echo Dr. Hoag and Dr. Cotton's encouragement for flexibility. I actually have patients who got the bivalent booster in early September and have asked me to write an off-label permission to get another bivalent now because they're traveling for the next couple of months. There are people who are actively wanting regular updates on this. So if I were to make a suggestion on this one specifically, I would make a recommendation that everyone get an annual booster, and that would be a regular recommendation and then a shared decision-making recommendation that certain categories of people, such as immunocompromised and people over 65, could decide along with their provider that they might want to get one every 6 months. I'm making up those dates, but that's just a thought. With regard to the children who may need a primary series, I would probably reframe that question, because for me, it's not really children. It's a question of whether you've had a primary series or the disease. And so if I've got an 11-month-old who's had COVID, and Dr. Jones said that there's good evidence that if you've had the disease, that a booster would then be sufficient, it's not that it's an 11-month-old, it's someone that's got evidence of having the disease. So I would frame it that anyone who hasn't had the disease and hasn't had a primary series should be considered for a primary series, but if you have evidence for a disease, then you wouldn't need that. So those are my suggestions.
Dr. Daley.
Yeah. Dr. Lair, I just wanted to comment that those suggestions we'll take back to the work group, but I think they're tremendously helpful in this conversation. I will also say that I believe that our colleagues at the FDA, who we've worked really closely with, will also appreciate the importance of flexibility, and I think that's a goal that they're working towards. Not to speak for them, but my impression is that that's definitely a goal that they're working towards as well. So sometimes in these meetings, there are comments made by my colleagues that really resonate and that I think about hours and hours later. And one of the comments made yesterday, both by Dr. Cotton and by Dr. Talbot, has really resonated with me, and I've been thinking about it ever since, which is we need to study these vaccines in the populations that we really need the best evidence for, because those populations are particularly vulnerable, of special interest, and we need to really push for that. I was so struck by those comments, and I have not ever worked in industry, so I appreciate that these things need to happen in a stepwise manner, and that for many things it is safest and most appropriate to first study in a healthy population. But once the safety and effectiveness has been established in a healthy population, I think we can quickly move towards studying in particularly vulnerable populations, and that should be part of the process. It should be baked into the cake. And so I think I would make a couple suggestions, and again, I don't know entirely if these are the best suggestions or the only suggestions, but I would argue that it would be ethical to have a randomized controlled trial of co-administration, COVID vaccine and influenza vaccine, with the other arm being separate administration, and we would learn a lot about immunogenicity and safety, and that might be valuable for this conversation, right? So again, a randomized controlled trial. So I think we need to distinguish between what we're going to learn from observational studies and what we're going to learn from RCTs, and when is it appropriate to do RCTs in the context of that comment about let's study the vaccines in the people who need them the most as we have this program. And another would be, frankly, there may be an opportunity to study in particularly vulnerable populations. Everybody gets a booster in the fall and then are randomized to get an additional dose 6 months later or not. And again, maybe that is not feasible or not ethical, but I think we need to have that conversation. So again, strong emphasis on, for the sponsors and for our colleagues at the FDA, moving quickly to additional data in vulnerable populations that can help us make these decisions. Over.
Thank you, Dr. Cotton.
wanted to just respond to that. Thank you very much for your eloquent remarks. I do think that in many of our deliberations over the past few days, it would be really helpful to have additional data on the most vulnerable populations, either immunocompromised patients or comorbidities, and it might be adult and it might be pediatric, but a lot of the data that we're looking at is just general population and actually sometimes excludes from the studies the most vulnerable or people in most need of vaccine. So I would like to second everything you said about thinking about RCTs and including them with a focus on the people who may actually benefit the most from vaccine. So thanks very much for your remarks.
Thank you. Dr. Grubb?
Hi, thank you very much. And I really appreciate all the presentation so far. I just want to, 2 points. I wanted to reinforce what you just said about the importance of research. And then the second point, because everyone else has already articulated it so well, I think it's so important about the messaging about it. I completely agree with simplification, but there's also a very large group of people who follow this very closely and they are aware of different levels of risk. And I think it's very important for this group to clearly articulate what the risk is for different people in terms of making decisions, both for the immunocompromised conditions and also really for in the future for people in the 18 to 50-year-old range as they're making their decisions in the future. And also, I just wanted to reiterate, I think it's really interesting about the monitoring for immunity and how it may or may not wane over time and how that's going to influence our future decision-making for when we're making recommendations for boosters in the future. So thank you very much.
Thank you. Dr. Kim? Sorry, I just want to acknowledge that you're from Novavax. You look like you raised your hand again.
Yes, this is Denny Kim from Novavax, and I thought I'd offer some more context. I think perhaps my previous answer was may not have been very satisfying in that we are in discussions with the FDA. I did want to say, just in the context of the discussions in the ACIP, that our vaccine regimen in the framework of a simplified regimen, that our vaccine for 12 and over primary series is the same dose and presentation. And so we feel that it's already simplified, and it's also approved for a booster dose as well after the primary series. And we are working on a bivalent formulation as well, and we'll be prepared to deliver that based on what the FDA advises for the fall and winter campaign. And we are also working on, we have a clinical study, age de-escalation clinical trial that does utilize the same dose as the primary series for 12 and over. Thank you.
Thank you. Appreciate the additional clarifications. Dr. Schaffner.
Thanks, Dr. Lee. I would like to first of all thank everyone who's put this extraordinary session together today. It's been most useful. But I'm speaking today to reinforce something that Dr. Hoag said, my colleague. It's a very practical point. It's been mentioned several times in previous meetings of this group, namely the importance of single-dose formulations. That could potentially expand the number of locations across the country where vaccine would become available. I think more physicians' offices and clinics and perhaps even pharmacies would be ready to provide vaccine. You know, there's a certain reluctance to go into a multi-dose vial if you only have one patient in front of you who needs the vaccine. I think we could enlist many more, at least physicians, to be active immunizers in the medical home if we had single-dose formulations. Thank you.
Thank you, Dr. Schaffner. Are there any other members that would like to weigh in or express a different opinion? I did want to just add a couple of comments, and I've been thinking about some of the comments throughout the session. So on the one hand, I actually prefer simplified messaging for the broader population because I think our messaging has gotten so complex that it's a barrier for people to understand how to best protect themselves. On the other hand, I do think the flexibility for individual clinicians to be able to work with their patients makes a lot of sense. Because there are always going to be situations or circumstances, and as long as we can do that safely, I think that's the most important thing. The challenge to us is that if we oversimplify the message, it's actually not helpful, and at the same time, if we allow for flexible use, it means we need really, really strong, continued updating of clinical considerations to ensure that that benefit-risk balance is retained over time. So I don't have a right answer for you, but I have been thinking like just a couple simple points. So one, it is clear from the data that hybrid immunity is both the strongest and the longest, but all immunity wanes over time. So I am struggling because I feel like and this is my personal opinion, I'm struggling with the need to feel like I need to acknowledge that immunity is a combination of both infection and vaccination, which does not make our messaging simple in any way. But that said, I think that's the thinking where I am now and how then to define where our gaps in immunity are. So then going back to your three questions, I think about, who are the least likely to be immune. It's going to be the youngest children. So, 6 months to 2 years as just a starting point right now. But I do think a simple recommendation of that age group would just be much more straightforward. So, all of those children should get a primary series, and a very small minority of them have to date. And I think they're less protected, and that's why we're seeing higher hospitalization rates in that population. And then to your second and third questions, the oldest and the immunocompromised are more likely to get very sick from infection, even with full vaccination and even with prior immunity or prior infection. So I do worry that that is a gap in immunity that we need to address. And again, being straightforward about our recommendations for those two populations and being simple about it, I think would be extremely helpful. But then I don't have an answer for all of the rest because it is a little bit confusing. And so, that to me is the challenge that we have ahead of us. So those three questions I think are straightforward. It's the rest of it that I struggle with. The last thing, I wanted to just go back to the points that were made earlier about, again, giving us the confidence that we need to speak confidently about vaccines so that the public can have the confidence they need. And so when we are debating these points, we are debating them scientifically, but it makes it really hard to have a simple and a straightforward message when we have all of these caveats trying to ensure that we are explaining the uncertainty. So I do want to go back to our industry colleagues as well as the FDA to help us in thinking about there is the specific scientific question in front of us, and then there is the how do we think about ensuring that we are maintaining public confidence in vaccines. I realize those two are not always the same, but it would be really helpful to start to incorporate that thinking going forward. And then specific to the comment about the challenges of special populations, again, where the data are the most uncertain. It could be pregnant women, it could be immunocompromised. And honestly, for COVID-19 vaccines, throughout, it has been our youngest kids. We have had the most data for the adult population, and we have had the least amount of data for the youngest kids. So I do feel like, having that transparency about what the plans are in place, and again, thinking about that confidence issue as sort of one of the end goals. And then the second being that it actually is, I feel like we have to ask these questions in the meeting about, are you going to do this and it's not going to happen? Like for me, it would just be easier to have transparency about we've decided not to do this and this is the reason why. It's a little bit harder because I keep worrying that we want these studies to happen and I don't know if they're going to happen, and all of that uncertainty makes this decision-making even more complicated. So if there's a really good reason it can't be done, that would be really helpful to understand up front so that we understand then how to go about what other types of information do we need to make that decision. But it's just hard when we hear that there's it hasn't been discussed, because then we don't know where it's headed and we have to wait another few months to figure out what's going to happen. So those are my thoughts for the moment. Dr. Lair.
Thank you for those thoughts. I'd like to respectfully disagree. If a 11-month-old has had it seems that they probably don't need a primary series. I think a fairly simple message would be, if you've had documentation of a COVID illness, you don't need a primary series, no matter what the age. And if you don't have documentation, you would need a primary series. And I think that's a fairly simple message in and of itself. So I would emphasize that reframing would be my suggestion.
Dr. Sanchez.
I just want to say I agree with Jamie. Yeah.
Dr. Paling.
I would like to add that younger children do not have as robust of immune response, and I would like to have some data before I made that decision. And I think we can obtain exactly that data, and that way we could follow the science. The second thing I'm thinking about is, as we're trying to communicate clearly, what are we trying to prevent? We are trying to prevent deaths and severe disease. And one of the misperceptions is that children get mild disease. And it is true that death among children is fortunately infrequent. However, I think one of the perspectives we should be looking at is COVID-19 in the top 10 cause of deaths among the age groups? And the answer so far for all age groups is yes, which does further emphasize the importance of vaccination. And I'd encourage us to look at it from that perspective. Thank you.
Thank you. Dr. Daley.
Yeah, I'd love to come back to a topic that we discussed briefly yesterday, and the days kind of blur together just a little bit, but at some point in the last several days, I think we've discussed this several times, which is that, we have an opportunity for tremendous disease prevention through COVID vaccination if people get vaccinated, and I think if adults are uninsured or underinsured, then as we transition to a commercialized product, then those are individuals who will not have the opportunity by and large to be vaccinated. And so I would love to have at least some understanding of what is the possibility, feasibility, likelihood of some vaccines for adults program that could pay for vaccines for uninsured and underinsured adults. Kind of what is the feasibility and possibility of that happening? Thank you.
Hi, this is Sara Meyer. Thanks for that question. As was, I think, mentioned in earlier parts of this meeting, that was included as a proposal in the president's budget, but in order for that to be enacted, it would have to be basically authorized and funded by Congress. And I don't know if Dr. Romero wants to add anything there.
So, Dr. Daley, it is one of the things that keeps me up at night. I'll speak bluntly. We could run into an inequity cliff, right? And have populations that are clearly unable to access vaccine, populations that we know from previous years are at high risk for acquisition of disease, and we need to protect. So I can tell you that for my part, I'm actively working to convince legislature and people in general of the need for this. This will be an incremental program. This won't be something that will be started and be fully funded. I think that it will grow over time. We have a while to go yet, but CDC is committed to this. We think it's very important. I think it's very important, and we'll continue to champion this issue forward.
Thank you, Dr. Romero and Dr. Meyer. Are there any other questions, comments? Dr. Talbot.
Some of this is a thank you, and some of this is a we're here to support you. This has been one of the best meetings for me since we've coined the word VFA, and we've been talking about vaccines for adults. It's one of the most fulfilling reasons that I do ACIP is knowing that we can actually give adults a healthier life. And so thank you for discussing it this time. Thank you for the enthusiasm, and thank you for working on this. I know it is not easy to change the course of a ship, but thank you. It is appreciated, and I won't start chanting VFA.
Thank you. I think with that, we are going to try and adjourn the meeting. So I want to thank all of our speakers, our CDC colleagues, our ACIP members, ex officio members, and liaison members. Oh, I see. Okay. Dr. Freihofer.
Thank you so much, Dr. Lee. Sandra Freihofer, representing the American Medical Association, but speaking as a practicing physician. I also wanted to amplify Dr. Schaffner's plea to have single-dose vials or preferably pre-filled syringes available, and to allow practices to purchase vaccine in small quantities. Also a reminder, and I know ACIP has their hands tied, in my office, our current supply of bivalent vaccine is about to expire. So if there is going to be a recommendation for an additional vaccine, I would really hope that we would hear about that before those vaccine doses expire. And just also to express appreciation to this whole process through vaccination and through mitigation efforts. I haven't lost a patient to COVID yet. And I have a practice filled of older patients with immunocompromising conditions and multiple medical conditions. And I really, in my heart, know that our work on COVID vaccines and making these vaccines available have saved so many lives and had such a major positive effect on my practice. And also, there are patients that, we all have vaccine fatigue, but there are patients, as was mentioned early in this discussion, that would like to get an additional dose just to keep that protection. And finally, the role of antibodies. Patients keep asking about antibody levels. They want to get their antibody levels tested. Maybe I wish we had more information about using antibody levels to perhaps recommend who needs a booster when. And again, thank you for a great meeting, and that's all.
Thank you. Dr. Wharton, do we have any further business?
We do not, Dr. Lee.
Thank you. I want to thank everyone again for all of your time and your efforts. It has been an incredible 3-day meeting. We are very grateful for your willingness to be here, be present, and to deliberate so transparently and in such a timely way with the public in mind. So, any objections to adjourning today's 3-day meeting? Wonderful. I see no objections. And I hear no objections. So today's ACIP meeting is now adjourned. Thank you, everyone.